the examiners for this topic presentation, and it will be a model exam for the future upcoming exams. Dr. Mubarak KK, who is heading the Department of Anesthesiology at Government Medical College, Calicut, and Dr. Vijesh Venugopal, who is a professor in HOD, Department of Anesthesiology, KMCT Medical College, Calicut. I take this opportunity to welcome Dr. Mubarak, Dr. Vijesh Venugopal, and Dr. Farsana N and Dr. Safa Kunyin, who is the core for this academic activities. Also, I take this opportunity to welcome our Honorable Secretary, Dr. Vinil Isaac Matthew, all the teachers, senior members, and today's participants. Now, over to Dr. Giri. Dr. Giri, please.
President, good evening, everybody. I'm happy that the program is going well and uninterrupted every week for the benefit of PG students. With the new modes of examinations coming like OSCE and all, we have started early with this OSCE this day. And we have good examiners who are experienced in both DNB and MD anesthesia, Dr. Mubarak and Dr. Vijesh. I hope PGs will benefit, and there are demand for our PG exam other states also. Dr. Kameshwar was asking yesterday the link, and he has spread. Many people have told they have communicated to others. With this, it is gaining more popularity, and I wish all the best. I beg your pardon. I wish to leave and go to the West Bengal for their conference. I came in between from there to attend because it is my home state and I have to attend here at 6 o'clock. So all the best. Once I finish that, I will come back here. All the best. Thank you.
Thank you, Dr. Venkatagiri. Dr. Rajesh MC, the Chairman, Academic Committee of Kerala State. Dr. Rajesh. I think Rajesh is not there. We'll straight away go to the examiners, Dr. Mubarak. Rajesh, please.
Sir, Dr. Rajesh is ready.
Yeah. So we are very fortunate.
Yes, Rajesh,
we are very fortunate to have a very eminent examiners. Mubarak sir is a regular examiners for MD and DNB examination, and also it's inspector for IMC and DNB programs. And we are very fortunate to have him here. So also Dr. Vijesh Venugopal is one of the main pillars of our program coordinator, and is a regular quiz master for the ISA programs, ISA academic programs. And this is going to be a new norm for the postgraduate examination for DNB and MD. And not only is that, it's a regular norm for the fellowship programs abroad also in Canada or UK. So I'm sure that our postgraduate students are vastly going to experience a different thing, and they are going to benefit a lot with this program. And over to Mubarak sir and Dr. Vijesh.
Okay, thank you, Dr. Rajesh. First of all, I thank the ISA Kerala State Branch for taking the initiation for this new OSCE-based CME program this week for the postgraduates. And I sincerely thank our postgraduates residents, Dr. Safa and Dr. Fasna, for volunteering and coming to participate in this program to make this program lively and more interactive. So before starting, I'll just tell a few things about the OSCE pattern. OSCE model of exams are recently coming up more because of the COVID scenario and all. Previously in Tamil Nadu, we had OSCE based questions in the university exams in Tamil Nadu. It is still going on. It is there. It is there in Tamil Nadu already. Continue. And recently, because of the COVID scenario, the national board has taken a stand for the last 2 exams to avoid the patient interactions, and the practicals was done through the OSCE based platform. And for this DNB exams, the out of the 300 practical marks was 300, and 200 marks of that was for OSCEs. 25 OSCEs or 5 to 6 minutes. Each carries 8 marks, which That means 200 marks are there for the OSCE alone, 25 OSCEs, and the practical part, the two cases of 30 marks, 60 marks each, and 10 into 4 of Viva, 40 marks. That is 100 marks. So out of 300, 200 marks is OSCE, and if you score 150 marks in OSCE alone, you have passed already even without the practicals. That is the so OSCE carries very important marks, very important the DNB. So I thought we'll have a OSCE based session, especially for the DNB postgraduate. Now the theory exam is over and practical, and the exam and the result is being awaited. And I don't know whether the DNB will continue with this scenario with this pattern also. Anyhow, it has already been started and 2 exams are over. And OSCE means there are different topics. We are not discussing a topic in details. So each questions carries 5 to 6 minutes only in the exams. So in that pattern, we discuss only 5 to 6 minutes of each questions, each OSCEs. So we don't aim at a detailed discussion or a thorough interaction, just to throw light to these different areas, like what is being done in the OSCE exam scenarios of the National Board particularly. So fortunately, I had been part of this last 2 OSCE-based exams also. So I thought I'll share that experience in training the postgraduates, especially the DNB appearing postgraduates. And I am sure this will benefit the other postgraduates where there is no OSCE-based exams, like in Kerala University of Health Sciences, there is no OSCE-based, but the same subjects are, it will be useful for the practicals, theory, as well as the Viva sessions. So with this brief introduction, Vijay, shall I start with the OSCE questions, or are you going to start first one?
No, sir, you can go ahead, sir. Please start.
Okay. So I'll be projecting questions one by one each. So each questions we take an average of 5 to 6 minutes for each OSCE questions. So that's how we are planned. So this is to throw light to certain areas of the topics to the postgraduates, as well as to get a training for the postgraduates in case the DNB is continuing with these OSCE based programs. So I'll put the questions to one of the residents, Safa or Fasna, and they will answer. And after that, we as a faculty, myself or Vijish will supplement their answers. And if the organizers has anything to add or think, they can do it as and when. So I'll be starting with the first question now. Shall I start?
Yes, sir. Yes, sir.
Okay. So this is the first question. So name the plant, common name and the scientific name, drugs obtained from this plant, which is medically used, as well as there is another drug which is often misused. What are signs and symptoms of overdose of these drugs, and principles of management of overdosage? I think Safa will start with answering this. Safa, am I audible?
Yes, sir, you're audible.
So am I audible?
Safa, yeah, you're audible, Safa. You can answer.
Yes. The common name of the plant is Opium poppy, and the scientific name is Papaver somniferum. Drugs obtained from it are opium and heroin. Opium drugs include morphine, codeine, thebaine, and all. Then signs and symptoms of overdose. The patient can present with the triad of meiosis, then central respiratory depression, and then hypoventilation and coma. Then the principles of management. The basic principle of management is mechanically ventilating the patient if he goes in for central respiratory depression. Then the antagonist is naloxone. It is given in a dose of 1 to 4 microgram per kilogram dose, but it is short acting. So we will have to put the patient on infusion of naloxone.
Okay, Safa. So the plant shown was opium poppy plant, and this botanical name or scientific name is Papaver somniferum. The name somniferum itself gives the meaning that it produces sleep. That is a somniferum, Papaver somniferum. So from this plant we are getting the opium alkaloids, and the misuse drug is heroin. Heroin is also product of opium. So these are the alkaloids which Safa has already told, and the morphine is extracted or got from the poppy straw. And the morphine, the word morphine has come from the word Morpheus, which has the meaning of Greek god of dreams. So opiate overdose, Safa has already told the CNS depression, lethargy, meiosis, and also there is cardiovascular symptoms like peripheral vasodilatation, hypotension in overdosage. There may be nausea, vomiting, neuropsychiatric symptoms, and it can also cause seizures. So overdose can be accidental or suicidal, and people may take injections or inhale or patches for misuse and all. Remove. So if there are such patch or thing, you have to remove it, or if somebody is getting an infusion, you have to stop it, and follow the ABCD protocol, assist respiration, CPCR if needed, and the specific antagonist naloxone, Safa has told, and it can be given in any routes, but IV is the preferred one, and it may require repeated doses. And in case of large oral intake of opioids like morphine tablets, now we are giving for palliative care therapy and all. So in such cases, activated charcoal or bowel irrigations are also used as the part of the management. So with that, I think I'll come to the first question and we'll go to the next question, and I think first I will focus to it.
Yes, sir.
Asna.
Yes, sir.
So we all know that the American Heart Association has come with the new AHA guidelines regarding the cardiopulmonary resuscitation in 2020 right now. So I think first I will highlight a few points regarding the newer changes, the key changes in the guidelines with respect to BLS, ACLS, maternal resuscitation, and pediatric resuscitation.
Yes, sir. The chain of survival has added a sixth link known as recovery, which forms the sixth link in the chain of survival. And the changes in the BLS, basic changes in the BLS and ACLS are, they are advising early administration of adrenaline, epinephrine, within 5 minutes of cardiac arrest. And also the use of amiodarone and as well as lignocaine has been given equal preference. And if you suspect opioid overdose, they are telling us to give naloxone instead of considering it. And then the dosage of atropine for bradycardia has been increased to 1 milligram. And then the dopamine infusion rate has been changed to 5 to 20 microgram per kilogram per minute. These are the key changes in BLS and ACLS. In maternal resuscitation, the peripartum cesarean section has to be done within 5 minutes of cardiac arrest in mother.
It's not peripartum, perimortem, Hasna.
Perimortem.
Slip of tongue, okay.
Yes, perimortem cesarean section. Earlier it was 4 minutes, but in the new guideline it is 5 minutes duration. And in pediatric resuscitation, every breath has to be given one breath every 2 to 3 seconds. And also the preferred method of giving CPR is the thumb encircling method. Umbilical vein catheterization can be considered, and also cuffed endotracheal tube is being considered in the latest guidelines. And also newer methods of double sequential defibrillation, a coach for CPR coaching, and in situ training are additional extra concepts that has been come into 2020 CPR guidelines.
Okay, first now you have done well, and I think all the postgraduates going for the exams now has to be thorough with this these guidelines. That's why I put it as in the initial slide itself. So almost all the points has been told by Pasna. So the sixth link has been added as the chain of survival, and almost all has been described by Pasna. I'm not repeating it. So the in ACLS, amiodarone and lidocaine are considered as equivalent antiarrhythmic drugs. Intravenous route is always preferred. Regarding maternal resuscitation, the main thing is the perimortem cesarean section. The time has been extended from 4 minutes to 5 minutes. So how do you know that it is 4 minutes or 5 minutes? So as soon as the maternal cardiac arrest has occurred, one has to document the time of its occurrence. Then you cannot estimate the time. So 1 minute is crucial. So the caregiver should note the time of the maternal cardiac arrest and go for perimortem cesarean section as part of maternal resuscitation as well as the fetal survival when the ROSCE is not achieved in 5 minutes as against the 4 minutes. And separate cardiac arrest algorithm for maternal cardiac arrest is there. You can go to the net and see it. I'm not going to details of that. And pediatric, the newer thing, the cuffed endotracheal tube has been advised or to consider in pediatrics. And the thumb encircling compression in infants is advised rather than the 2 finger compressions. So, with this, I think we'll go to the third question next to. Okay, the pediatric link is also has a 6th link as in the adult link, both in the in-hospital as well as the out-hospital cardiac arrest. So we'll go to the third question to Safa. Safa, please read out and you can tell your diagnosis and answers.
This is a chest X-ray AP view of right-sided pneumothorax in a mechanically ventilated patient. The clinical features are basically the patient can present with sudden onset. In this patient, the patient can present with sudden onset right-sided pleuritic chest pain and dyspnea. Then on examination, there will be tachycardia, hypotension, then pulses paradoxes, then decreased breath sounds on the right side, then hyperresonant nodes on percussion, then trachea may be deviated to the right side. Then the predisposing factors are in a mechanically ventilated patient, it might be due to barotrauma. Other predisposing factors are smoking, then in marfanoid habitus, presence of bulle, all are predisposing factors for pneumothorax, or any kind of chest injury and all can cause pneumothorax. Then management, tube thoraco in a mechanically ventilated patient, if he develops pneumothorax, the management is tube thoracostomy. It is done in the triangle of safety with anterior border with the lateral border of pectoralis major in the anteriorly, then lateral border of serratus anterior, means latissimus dorsi posteriorly, and the fifth intercostal space forming the lower border of the triangle. That is the management.
Safa, can you are diagnosed as a right-sided pneumothorax in a mechanically ventilated patient. Can you just describe the positive features in the chest X-ray? How did you came to a diagnosis? And just please read the X-ray.
This is chest X-ray AP view. It is not rotated. Exposure is adequate. Then
how do you diagnose a pneumothorax in this chest X-ray?
Here the lung shadows on the right side, there is a delineation on the right side with a decreased translucency.
Perlucent.
And we can see the endotracheal tube in the trachea. Then also we can see the ECG leads.
What is
So
the
we
difference?
understand that the patient is, seeing the endotracheal tube, we understand that the patient is mechanically ventilated.
Safa, what is the difference in a patient developing pneumothorax in a mechanically ventilated patient or in a spontaneously breathing patient?
Mechanically ventilated patient can go in for tension pneumothorax more quickly than a patient developing spontaneous pneumothorax.
Why do you say so? What is the reason for that?
Because we are giving positive pressure ventilation in mechanical ventilation. Normal ventilation is negative pressure ventilation. So there is no positive pressure being created in the thorax.
First, can you just tell me the ultrasound diagnostic methods of identifying pneumothorax in the ICU? Because a portable X-ray, it may take time and it may be difficult nowadays. Ultrasound focus is available everywhere. I think Pasna will just throw some lights on the ultrasound diagnosis of pneumothorax in the ICU.
When an ultrasound probe is kept over the intercostal space, the lung shadow can be seen, lung and the pleura can be seen as a seashore sign. The pleura will be the waves and the moving lung parenchyma will appear as sand, thereby giving a seashore sign. This sign is absent in pneumothorax and which is replaced by a barcode sign where this movement is not seen. It is also known as stratosphere sign.
So having a focus on bedside ultrasound will be more diagnostic. Okay. So I think we'll just rush through the answers. So this is a right side pneumothorax, which is showing air in the pleural space, and the clinical features Safa has already told. And in mechanically ventilated patients or in IPPV, there is a likelihood of tension pneumothorax, which has to be immediately managed, either by a needle compression quickly or by a tube thoracostomy. So the diagnostic features are decreased breath sounds, pulses, paradoxes, hemodynamic instability, contralateral tracheal deviation, and sudden increase in the airway pressures in mechanically ventilated. So the needle compression, the usual site is the second intercostal space, the midclavicular line. But if the patient is obese and difficult, the fourth or the fifth intercostal space in the mid-axillary line can be tried in such individuals. And tube thoracostomy is needed if there is massive pneumothorax. I think we'll change over to the next Dr. Vijish to continue with the next few questions. Vijish.
Good evening, everybody. This is the first slide that I would like to show. And the first question would be to Safa. Safa, could you identify this graph that is showing percentage saturation versus the PaO2?
This is oxygen hemoglobin dissociation curve.
What are the factors that affect this curve?
Yes, sir. The factors that affect this curve are temperature, then hyperthermia, hypercarbia, then acidosis, then increased concentration of 2,3-DPG, all causes right to shift to right and shift to left, vice versa.
Okay, that means if the temperature, PO2 and 2,3-DPG increase, it will be shifted to the right. Okay, fine. Next question, go to Fasna. Fasna, why is this ODC sigmoid in shape?
That is because of the positive cooperativity that we see. One hemoglobin binds to 4 oxygen molecules. After the binding of one oxygen molecule to the hemoglobin changes its configuration to a relaxed mode so that the subsequent binding of the oxygen becomes easier, and then you get a sigmoid shape, and later it plateaus.
That's a facilitatory binding of oxygen that is responsible.
So.
right? And can you identify this X mark on the ODC? Pasna?
So that will probably be the P50. P50.
Yeah,
That is the partial pressure at which hemoglobin is 50% saturated. The normal value of which is 27 millimeters of mercury.
what is the significance of this P50?
P50 measures the affinity of hemoglobin towards oxygen. When the P50 is at lower value, the affinity of the hemoglobin to oxygen is higher, and it is varies if it becomes at if the P50 value is higher, the affinity is lower.
Yeah, correct. So as both of you said, these are the factors that affect the curve. And the sigmoid shape, as you said, it is because of facilitatory binding of oxygen to hemoglobin, whereby the affinity increases with the binding of oxygen. And P50, as you said, is the conventional measure of the affinity of hemoglobin for oxygen. And you can get some other questions based on this ODC. Some other questions can come up in your examination. One question that could come up is the Bohr effect. So Safa, could you just throw some light on what is Bohr effect? You have to unmute.
The deoxygenation of hemoglobin in a background of high PCO2 and increased levels of H plus acidotic environment describes the Bohr effect. Then double.
Yeah, okay, fine. So the Bohr effect means that hemoglobin will load more easily in the pulmonary capillaries and unload more easily in the tissue capillaries. That is the effect of the Bohr effect. Fine. Now, Fasna, could you throw some light on double Bohr effect? Where does double Bohr effect take place?
The double Bohr effect occur at the fetal-maternal circulation, that is at the placenta, where the carbon dioxide concentration in the maternal blood will be higher and it will be more acidic. Thereby, it releases oxygen to the fetal circulation, and the fetal and the reverse occur in the fetal side. So the Bohr effect is happening in two different directions at the placenta. That is double Bohr effect.
Yeah, so that's the double Bohr effect, and that's because of the carbon dioxide transfer to the mother, whereby the fetal pH increases and there is a increased oxygen affinity at the fetal side of the placenta. And for the mother, it's the opposite. And all this happens just because you see there's a histidine site there. You can see there on the hemoglobin, and carbon dioxide binding to this sentinel histidine on hemoglobin chain can block the access of oxygen to the heme binding site, and that is the one that is responsible for causing this double Bohr effect. Next would be the Haldane effect. Safa, could you say what is Haldane effect?
Haldane effect occurs in the lungs. The deoxygenation of hemoglobin increases its ability to carry carbon dioxide, and oxygenation decreases the ability to carry carbon dioxide. This explains the Haldane effect.
So Haldane effect is the one that takes place at the respiratory epithelial level, while the Bohr effect takes place at the capillary endothelium at the tissue level. Correct. And along with this, you find that there is something called chloride shift. So Fasna, could you throw some light on this chloride shift, or what is known as hamburger phenomenon?
Chloride shift or hamburger phenomenon occurs during the transportation of carbon dioxide in the form of bicarbonate. The bicarbonate concentration inside the RBCs will increase. And because of this increased concentration of bicarbonate, this will diffuse outside the cell, outside the RBC. And in order to maintain the electrical neutrality, chloride enters the red blood cells. Thereby, a shift occurs using this carrier protein, and this is known as hamburger phenomenon.
Yeah, so it doesn't diffuse out, it is exchanged by the exchanger protein band 3, the anion
Band 3
exchanger
protein.
protein. Yeah, it doesn't diffuse out because this cell membranes are generally impermeable to the charged ions like chloride and bicarbonate. So what happens is as you said, and as shown in this picture here, there is a reverse shift that happens in the lungs, and at the tissue level, the chloride moves in, whereas at the lung level, the chloride comes out. There's a reverse chloride shift also. So consequently, what would you say, in which blood, is it the arterial blood or the venous blood, that the chloride concentration is going to be high?
In arterial blood, chloride concentration will be higher.
Correct. The chloride concentration is lower in the systemic venous blood than
Venous
in
blood,
systemic arterial
arterial
blood.
blood.
Really right. So these are some of the questions that you can get based on the oxygen dissociation curve. So this is both of you have answered it well. So we go to the next set of questions that could come up in your DNB examination. So these are based on vaporizers. So Safa, could you explain what is SVP, or saturated vapor pressure?
Saturated vapor pressure is the pressure exerted by a vapor on the walls of a closed container when it is in equilibrium with the inhalational agent. And MAC, it is the minimum alveolar concentration of an inhalational agent which is required to immobilize 50% of the individuals to surgical stimulus at 1 atmospheric pressure.
Totally right. So MAC, again, there are different types of MAC, right? Could you throw some light on that? How many types of MAC or different types of MAC that you know?
MAC bar means it is the minimum alveolar concentration which is required to blunt the adrenergic response in 50% of the individuals. Then MAC awake means it is the minimum alveolar concentration required to bring 50% of the individuals into awake state. Then
Okay, first, any more you know?
MAC intubation, similar to the MAC bar, in order to the MAC required to keep the patient completely perfect.
Yes, it's only for 50% people, no? Your MAC is only
Yes,
for where
50% unpremedicated patients.
actually, till MAC was introduced, what was being used to quantify anesthesia? It was the ice signs and all, no? That Goodell signs were being used. And in 1965, it was Thomas Eager who
Udall
introduced
stages.
MAC into clinical practice, and it tells you something about the potency of the anesthetic agent. So till that time, we had to use qualitative variables, and this was the first time that we got a quantitative variable, right?
Numerical value.
And very recently, last year in August, Thomas Eager passed away. Okay, fine. So now, can you estimate the amount of anesthetic agent used if you set isoflurane 2% on the dial and a fresh gas flow rate of 2 liters per minute?
yeah, set percentage into
Yeah.
fresh gas flow into hours delivery.
Actually, it's into a constant 3. And for sevoflurane, they use it as 3.3. So this can be approximately, you can calculate the amount of inhalational agent that can be used, depending upon the set percentage and the fresh gas flow. So there's into a constant, and then so if it is 2% on the dial, so 2% into fresh gas flow, if you're
Gas
using a
flow.
closed circuit, around 2 liters per minute or 1 liter per minute, into 3, that is a constant. And for sevoflurane, it is 3.3. So you get a approximate value of 12 mils per hour. Next, Fasna. on this dials, you can see some, I have rounded one thing on the dial. It's on the other side of 0. What does that indicate?
To transport.
Correct. Why do you want to put it on that and transport?
Pass into the other chambers.
Yeah,
Into
so
the bypass
tipping,
chamber.
correct.
Tipping
Absolutely
should
right.
not
So
occur.
so tipping is hazardous because it discharges, as you said, it discharges liquid agent into the control mechanisms or distal to the outlet, right? So do you know any other vaporizer which you can tip?
Desflurane.
The newer one, the Vapor 2000 units can be tipped. Any other one?
Halothane, sir.
These cassettes can be
Cassette. Aladdin cassettes.
Yeah, so Aladdin cassettes can be tipped. It's only a liquid sum without any control mechanisms. So they can be tipped into any orientation without any danger. Okay. So there's one scenario, Safa, though we don't do it, you have a halothane vaporizer with you. And unfortunately, halothane has run out in your department, but you have all the other ones, isoflurane, sevoflurane, and fluorine. Though it is not allowed, which would be the one which you would use?
Since halothane and isoflurane are very close to each other, they have similar saturated vapor pressures of around 250. It is isoflurane can be filled in halothane, probably if a question arises.
Yeah, because of the nearby saturated vapor pressures.
Saturated
Still,
vapor.
the splitting ratios will be different, but still, this could be the best bet when you don't have halothane. Okay, fine. Next scenario to Fasna. Now, what happens to the vaporizer output when isoflurane vaporizer is taken to Munnar from Calicut to give anesthesia? And you imagine that the barometric pressure at Munnar is 380 millimeters of mercury, and at Calicut it is 760. So you're taking to a place where the barometric pressure is half. You're taking an isoflurane vaporizer.
So when you take isoflurane vaporizer, which the concentration high, but variation is only very little. So that will not make any clinical difference when you take a isoflurane vaporizer to a higher altitude place like Munnar from Calicut. But the yes, there won't be any much of clinical significance in the clinical effects.
Yeah. That's because the output in volume percent into barometric pressure is equal to the vapor pressure, and you can calculate what would be the output of this vaporizer at a altitude. If you are using it, it's the output actually, the vapor output or the vapor output percentage will increase. However, according to Dalton's law of partial pressures, this 2% isoflurane that comes out at 760 millimeters of mercury is the same as 4% isoflurane at 380 millimeters of mercury, because it is 4% of 380 millimeters of mercury, which is 15.2, because everything should add up to 380. So it's only 4% of 380. So the output is going to be the same. But what about your desflurane vaporizer?
Sir, in desflurane vaporizer, it depends upon the principle of differential pressure transduction, the working of the desflurane vaporizer. So the change, the partial pressure of the agent will vary. So there will be clinical significance if you take it to a higher altitude.
Correct. That's because the number on the dial reflects the percentage that will be delivered. So at any altitude, when you dial 5%, it will give you 5%. But when that 5% desflurane leaves the vaporizer at high altitude, what is delivered to the patient is 5% of that decreased ambient pressure, right? So just like your principle that you followed here, that 5% of the decreased ambient pressure should be calculated. So you will need to dial a higher concentration at high elevation to attain the same clinical effect. Okay, so we end vaporizers here and we go to the third question. Safa, can you name these? This is a vertebrae. So can you label the parts? I have labeled it as A, B, C, D, E, F, and G.
So A is the spinous process. B is the lamina. C is the transverse process. D is the vertebral canal. Then E is the vertebral body. Then F is the pedicle, and G is the articular process.
The articular process. They have two, right? There will be inferior and superior articular process on either side. So you have 4 processes which are for the joints and 3 processes for attachment of muscles and ligaments. So next, Fasna, could you explain the approaches to, or could you name the approaches to spinal anesthesia?
The most common median approach, paramedian approach, and then Taylor's approach.
What is this Taylor's approach?
Taylor's approach is done through L5S1 interlaminar space, L5S1 space. After introduction of the needle, it is tilted to cephalomedial direction.
Yeah. So it is the largest interlaminar space of the vertebra.
Space. Column.
Okay. Now, Safa, could you tell what are the structures that are pierced during spinal anesthesia?
The structures that are pierced during spinal anesthesia: skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, then epidural space, dura mater, then arachnoid mater, and we reach the subarachnoid space.
So what structures are missed in the paramedian approach? Or what you don't pierce in the paramedian approach?
The interspinous ligament and the supraspinous and interspinous.
Yes, you don't pierce the supraspinous and the interspinous ligament paramedian. Right. What is CC-CNS ratio? And what is the significance of that? First now.
CC-CNS ratio is the dosage of drug that produce cardiovascular collapses to CNS toxic features. The ratio will, the lower the value, higher the cardiac toxicity of the local anesthetic agent. For bupivacaine, it is 3, and for lignocaine, it is 7, making bupivacaine more cardiotoxic than lignocaine.
Yeah. So we should beware of the lower number 1, right? Which would be more cardiotoxic to the patient. So in general, in a patient who is under general anesthesia, what do you expect as the first sign of local anesthesia toxicity?
Bradycardia.
Yeah, it would be a cardiac toxicity rather than a CNS toxicity,
CNS.
right?
Yes, sir.
Okay. Now, what is the effect of this local anesthesia? What happens during pregnancy? What is the
in pregnancy?
effect?
There is increased risk of local anesthetic toxicity because of the increased sensitivity of the nerve fibers to the local anesthetic agents in pregnancy, and because of the decrease in the CS of volume in pregnancy, and also the absorption of the local anesthetic agent from the space is more because of the increased venous engorgement, and also alpha-1 glycoprotein is reduced in pregnancy, which make more free fraction of the drug, which can lead to systemic toxicity as well.
Yeah, absolutely right. Whatever you have said is correct, because pregnancy results in a progesterone mediated increase in the neural sensitivity to local anesthetics. There is decreased alpha-1 acid glycoprotein, and the space is also reduced. Now, suppose you develop, suppose the patient develops local anesthesia systemic toxicity, how would you go about it?
After initial stabilization of the patient, maintaining airway with 100% oxygen, specific treatment can be given with intralipid emulsion of 20% at a bolus rate of 1.5 ml per kilogram, followed by infusion dose of 0.25 ml per kilogram per minute. The bolus dose can be repeated 2 or 3 times, and the infusion rate can be doubled if the features have not subsided. Maximum of about 12 ml per kilogram can be given.
Well, yeah, fine. Thank you. Thank you, Safa and Fasna. And over to Mubarak, sir.
I think. Shall I share the screen now?
Yeah, sir, I have stopped sharing. You can continue.
Mubarak sir, please share the screen.
Okay.
And now it's visible.
So I'll go to the next question. So, Fasna, can you see the can you see the tracings?
Yes, sir.
Fasna?
Yes, sir. Yes, sir. These are the tracings of a pulmonary
please,
artery catheter.
Okay.
These are the tracings of a pulmonary artery catheter while introducing it into the heart, and the pressure variations at different locations of pulmonary artery catheter in the heart. First one is the right atrium. The pressure of around 0 to 6 millimeters of mercury, which is the right atrial pressure. And then comes the right ventricular pressure, which sudden upstroke of systolic pressure of 25 millimeters of mercury, and a diastolic pressure of 0 to 4 millimeters of mercury. And then it goes into the pulmonary artery. From the pulmonary artery, the systolic pressure of 25 and a diastolic pressure of 10 millimeters of mercury. And then the pulmonary capillary wedge pressure. Once you inflate it and wedge the pulmonary artery, it reflects the pressure in the left atrium, which is around 8 to 10 millimeters of mercury.
What's the name of the catheter you use for doing this procedure? Fasna?
Swan-Ganz catheter.
Yeah. Can you
Swan-Ganz catheter. Hello?
Yeah, can you just describe briefly what is
Swan-Ganz?
Yeah. Hello?
Swan-Ganz catheter is a catheter with multiple lumens. Hello, sir. Am I audible?
Yeah, you're audible. You're audible. Carry on. You're audible.
Swan-Ganz catheter is a catheter with multiple ports, and also there is a wedge, and there is a balloon tipped edge. As and when you introduce it through the central vein, you inflated the balloon with 1.5 cc of air so that it will not hit the other areas of the heart and cause arrhythmias. Then it has got a port for a thermistor is present in the Swan-Ganz catheter to detect temperature, and drug infusion can be given.
So what's the importance of measuring, say, PCWP?
The function of the left side of the heart, left ventricle as well as the right ventricle, can be assessed, and also you can differentiate between cardiogenic and non-cardiogenic pulmonary edema.
What are the complications?
Then other various indices can be derived from the complications of the procedure. While introducing the catheter, it can cause rupture of the vessel, the internal central vein, and it can also throughout it can cause arrhythmias if it touches the heart. Arrhythmias, then various types of tachyarrhythmias, perforation, hematoma can occur, kinking of the artery then that's also.
Okay, so these are the tracings of the while doing a pulmonary artery. When the catheter tip is in the right atrium, you get the right atrial tracings, which corresponds to which tracing? First now? It corresponds to
The first one.
Yeah, first one corresponds
Right
to which,
atrial.
yeah, right atrial pressure.
Right atrium.
Tracing is the CVP
0,
tracing.
4.
Yeah, the CVP tracing.
Corresponds to the CVP tracing.
The CVP tracing with the CVP waveforms, and as the catheter
CVP waveforms.
floats and goes to the right ventricle, you get the tall waves. And the third one is the position where the catheter tip is in the pulmonary artery.
Pulmonary artery.
And how do you wedge it? How do you get the wedge pressure when it reaches the pulmonary
By
artery?
inflating the balloon.
Yeah, once you inflate the balloon, it is wedged.
Inflate the balloon.
Yeah, inflate the balloon and you get the wedge tracing. So this is the
pressure.
Pressure tracing in the wedge pressure. Okay.
Wedge tracing.
These are the various pressures in the different intracardiac chambers, which Krishna has already told. The right atrial pressure, right ventricle, pulmonary artery, left atrium, left ventricle, and the aorta. And CVP measurement, the importance are, which she has already told. These are the importance of measuring the PCWP. Complications are arrhythmias during the process, thromboembolism, pulmonary ischemia, all those problems. So these questions throw just light to these topics only. We are not going to detailed discussions, and the discussion is not complete. So this is the pattern with which the OSCE questions are being asked. Okay, so I'll go to the next question to Safa. Safa, can you see the slide? Safa?
Yes, sir.
Yeah. Please identify the ultrasound tracing, ultrasound picture, and just give the answer.
This is ultrasound picture of the neck.
Which are the label structures 1 to 5?
One is sternocleidomastoid muscle. Then 2 is the internal jugular vein. Then 4 is carotid artery. Then 3 is thyroid gland. Then 5 is transverse process C6.
What is this image used for?
So it is used for central venous cannulation, internal jugular vein cannulation.
Okay. How do you differentiate between an artery and vein in an ultrasound picture?
Artery will be, first of all, artery will be pulsatile. Then it will be having thicker walls than vein, and vein will be compressible. Artery will be smaller than vein.
What about the shape? You can see a perfect circular pattern of the carotid artery 4, is it not?
Yes.
While that of the internal jugular vein is not of a particular shape, it varies, and as you compress with the probe,
it will be
collapsed. But the artery will retain its circular pattern. Okay. So this procedure is done for ultrasound.
Central venous cannulation.
Yeah. If you don't have an ultrasound, what is a landmark technique for doing an interjugular cannulation? Please tell me.
First of all, position
of the patient.
First of all, position the patient. We usually cannulate the right-sided internal jugular vein. So turn the neck of the patient to the left side. Then head down position is preferred to prevent venous air embolism risk. Then palpate for the carotid artery and towards the same side nipple, we insert the needle at the level of the thyroid cartilage. And once we get venous aspiration, we insert the cannula.
Why the right side is more often chosen?
Left side has got more tortuous course than a right side vein.
Oh.
So it is easy to access. Right side IJV is easy to access.
This is the labeling. the sternocleidomastoid muscle, thyroid gland, the IJV, which is larger and have a bizarre shape, carotid artery with a perfect round shape, and the transverse process of the cervical vertebra. Okay. Pasna, shall we go to the next question? Pasna?
Yes, sir.
Yeah.
Yes, sir.
Yeah. Please identify the tracings and tell me which are the 8 things labeled and define them.
Spirogram tracing, spirometry tracing, which is a spirogram. The first one is the inspiratory reserve volume. Second one is the tidal volume. Third one is the functional residual capacity. Fourth one is the residual volume. Sixth one is the expiratory reserve volume. Fifth one is the inspiratory capacity. Seventh one is the vital capacity. And eighth one is the total lung capacity.
There are 4 volumes and 4 capacities. Is it
4
not?
volumes. Yes, sir.
And 4 volumes and 4 capacities. So this is a spirogram which measures the rate at which the lung volume changes by breathing maneuvers. And so these are the 4 volumes and 4 capacities. Can you just define these volumes and capacities?
Functional residual capacity is the amount of a volume of air that is present in the lungs after normal expiration. After forceful expiration, the amount of air that is present in the lung is the residual volume. The tidal volume is the amount of air that is normally inhaled and exhaled in a normal respiration. After a normal respiration, the amount of air that can be filled in the lungs is the inspiratory reserve volume. Vital capacity is the amount of air that can be forcefully expired after the normal expiration. Total lung capacity is the total capacity of the lung, which includes the addition of all the volumes.
Safa?
Yes.
Can you just mention me what is the importance in the anesthesia practice, the importance of functional residual capacity?
Yes, functional residual capacity determines the apnea time that we get for difficult intubation. In case of pregnant ladies and obese patients, they will have a reduced functional residual capacity, which predisposes to difficulty during difficult ventilation. Patient can go in for rapid desaturation. So the idea of pre-oxygenation is to denitrogenate the whole of the functional residual capacity and fill it with 100% oxygen.
So these are the 4 volume capacities and the definitions. So I think I will hand over to Vijish for the next questions. Vijish?
Screen is visible, right? Safa and Fasna, you're seeing the screen,
Yes, sir.
right?
Yes, sir.
So next, the 4th OSCE from my side would be something regarding the closed circuit. So first question based on this would be, what are the carbon dioxide absorbent substances that are used commonly in practice?
Soda
Safa.
lime.
Soda lime, bara-lime, then lithium-based carbon dioxide absorbents like litholime, spiralith.
What are the common ones used are soda lime and bara-lime.
And bara-lime.
So you could be asked about how to write down this chemical reaction that takes place.
Carbon dioxide plus water giving carbonic acid. This carbonic acid reacts with sodium hydroxide or potassium hydroxide.
To form the carbonates.
Forming sodium carbonate and water. Then this sodium carbonate reacts with lime forming, regenerating the alkali and calcium carbonate.
Something else is also produced during this reaction, right?
Heat, exothermic reaction.
It's an exothermic reaction. So you can also mention that heat is there. Okay. Next to Fasna, what are the indicators that are commonly used? And what is the role of the indicator?
Indicators indicators indicates the like whether when the soda lime carbon dioxide absorber is exhausted, the indicator changes its color. The fresh indicator, when phenolphthalein, when used fresh, it is white in color. When it is exhausted, it changes to pink in color. Ethyl violet is when it is fresh, it is white in color, and when it's exhausted, it turns to purple in color. Titan yellow is off-white is pink in color, which turns to off-white in color.
The Titan yellow. Okay. Yeah, fine. Now, could you tell me what are some advantages and disadvantages of barrel lime?
Barrel lime reacts with halogenated alkanes like desflurane and form carbon monoxide, and also these can cause the formation of compound A, which is nephrotoxic.
Anything else?
This carbon monoxide can cause Monday morning.
Yeah, what is this Monday morning?
That is when in the weekends we don't use the theater, so the halogenated alkane will react with this barrel lime and form carbon monoxide in the canister. So when you administer that to the
correct. Yeah, go on. Correct.
When you administer initially the Monday morning after the 2 days of off, when you administer this gas to the patient, there will be increased concentration of carbon monoxide in the patient.
That is especially there is a mandatory oxygen flow that is kept on in the this one and on your machine, and it causes drying up of the barrel lime, and then this will be more prominent. Yeah, that's good. And could you name some newer absorbents that are being used? We are all commonly using soda lime, barrel lime. So which would be the one newer absorbents? Because of the disadvantages of soda lime and barrel lime, people have moved on to probably we have not used it, but there are some newer absorbents in the market. Could you just throw some light on it?
That litholime, there is no carbon monoxide production in litholime, and spirolith.
Yeah. The advantage of spirolith is?
It is hard.
Yeah, so there is no powder formation, right? So spirolith is lithium hydroxide and litholime is lithium chloride, which is the catalyst. So the main thing is you can avoid this toxic alkalis like caustic alkalis like your sodium and potassium hydroxide. Fine. Now, what is this low flow anesthesia? So Safa, what is this low flow anesthesia?
The form of anesthesia in which we administer fresh gas flow less than the alveolar ventilation of the patient.
And you want 50% going through undergoing carbon dioxide reabsorption?
More than 50% will be rebreathed by the patient after carbon dioxide absorption in low flow anesthesia.
Correct. So somebody has classified something called metabolic flow. What is this?
Metabolic flow means less than 250 milliliters per minute.
Yeah, fine. So we go to the next question or the next OSCE, that is to Fasna. Two paramedics have intubated a patient with full thickness burns, and while they were transporting this patient to the burn center, or rather they reached the burn center and they were connecting the monitors, and suddenly cardiac arrest ensues. CPR is initiated, and as you see on the picture there, that is the capnogram. So what value of CO2 is consistent with good quality CPR?
ETCO2 value of 10 millimeters of mercury is consistent with good quality CPR.
More than 10, right?
More than 10 millimeters of mercury.
You'd be happy
And
with more than 10.
Yes, sir. No,
So,
the return of spontaneous circulation has to occur after giving CPR.
yeah, fine. So that is the one that, what is the arrow that CPR was being continued, and you can see on that picture that suddenly the
There
ETCO2
is
goes
return
up.
of
So what is,
spontaneous circulation.
yeah, so this patient later, when they probably an hour later, this was what the capnogram showed.
These were the spontaneous, these are curare cleft seen with spontaneous respiratory efforts from the patient side. In a mechanically ventilated patient, when spontaneous efforts are seen, are taken, curare cleft are seen in capnogram.
Fine. What are the phases of that you see in a normal capnogram?
There is phase 1, 2, 3, and 0. Normally,
Normally it is phase 1, phase 2, phase 3, and phase 0. Where do you measure ETCO2?
At the end of phase 3.
At the end of phase 3. What is this difference between PaCO2 and ETCO2?
The difference between PaCO2 and ETCO2 gives the alveolar dead space ventilation. The value is which is around 5 millimeters of mercury.
What are the different types of capnography that you know of?
Side stream and mainstream capnography. The advantages of side stream. The advantages of side stream are it is lightweight, and it is lightweight, and calibration, automatic calibration is present in side stream. The disadvantage of side stream is that the sampling line can be kinked and water trap. Moisture is a problem. In mainstream capnography, the thing itself is bulky, which can cause kinking of the endotracheal tube, and kinking of and the disadvantage. That's the disadvantage. The advantage is that it is more accurate than side stream, and also it is more accurate and it's real time compared to the side stream capnography.
It's a Fasna had told about phase 1, phase 2, phase 3, and phase 0. Do you know anything about phase 4 on capnograph?
Yes, phase 4 is commonly seen in obese patients and pregnant ladies. This shows the decreased thoracic compliance on inspiration. So there is an upstroke at the end of phase 3 in capnograph. That is the phase 4.
Fine. That's right. There's a difference between the rapid and slow alveoli that are seen in these patients. Okay, I'll show you some signature patterns, and you can tell me one by one. The first one to Fasna. The one on the top.
Capnogram showing shark fin appearance, typically seen in bronchospasm.
Right.
The second one,
Yeah.
an extra angle, an extra phase 4 can be seen. That is at the end of phase 3. There is an upstroke that is seen in pregnant and as well as obese patients.
Right.
The third figure is the capnogram is going up the base level. That can indicate the carbon dioxide absorbent exhaustion and thereby rebreathing, occurrence of rebreathing.
Very good. Very correct. We go on to the next OSCE, that is the last one in this session on this part. So this is going to be a history, and based on this history, you should tell me what are the acid-base disorders that you anticipate. The 16-year-old male with sickle cell anemia, hemochromatosis, and subsequent cirrhosis presents with several day history of emesis. At presentation to the ER, he is hypotensive, orthostatic, and confused. So Safa, What are the acid-base disorders that you anticipate based on this history?
From the history, the patient has a history of several days of emesis. So probably he can have a metabolic alkalosis due to loss of acid from the GI tract. Then due to sickle cell anemia, the patient can have hypoxemia, which can lead to lactic acidosis.
Correct. What about hypotension?
Hypotension can also in turn lead to anaerobic metabolism and lactic acidosis.
What about his liver condition? Hemochromate subcirrhosis. He's having cirrhosis, right? It can cause decreased lactate metabolism, right? Okay, so you're expecting this patient to have metabolic alkalosis as well as lactic acidosis, right?
Yes.
From history.
Yes, sir.
So you have analyzed the history and this is what we are expecting. So this is what the pH and the electrolytes are shown here. Can you just work out briefly, not too much in detail, but just briefly, can you tell what this patient has?
Here the
From this-
pH is 7.55. Normal pH value is 7.35 to 4.5. So the pH is on the alkalotic side, and bicarbonate is 56. Normal bicarbonate value is 24. So metabolic alkalosis is explained, but here the carbon dioxide normal is 35 to 45. Here it is 66. So there is a compensation occurring in the form of hyperthermia. So PaCO2 is 66. So then we have to calculate the expected PaCO2 in this patient.
Okay.
So
I get that. Okay. We will think that the compensation is appropriate. Okay, we'll forget the calculation for the time being. What else will you look into?
we will have to look for the anion gap.
Yeah, because of the metabolic acidosis from
Acidosis.
lactic acidosis that you're expecting, no? So you should look at the
Anion gap. So anion gap here is 166 minus 90 plus 56.
that is coming to around it is 120.
It comes
Anion gap.
20. So normal anion gap is 10 to 12. So here there is high anion gap.
Correct. So this is a case of which is having there is metabolic alkalosis along with
High
high anion gap acidosis.
anion.
Very good. Yeah, fine. Over to Mubarak sir.
Okay. I think I'll go to question number 7. Fasna, would you please read out the scenario and the questions? Fasna?
Yes, sir. 30-year-old male. Yes, sir.
Yeah, please.
30-year-old male brought to the ED, confused and disoriented, closed head injury, loss of consciousness at the scene, now awake, pain at the back of the neck, a pulse rate of 90 per minute, a BP 100/70 millimeters of mercury, respiratory rate of 24 per minute, which is irregular. Patient has to be transported.
What are your concerns in this case? What are the problems?
The patient has got a history of loss of consciousness, which directs to a closed head injury following
following a head injury.
head injury, and also patient now complains of pain at the back of the neck, and also suspected cervical spine injury with a irregular respiration.
Okay. So go to the questions.
What are your concerns? My concern is the transportation of the patient and stabilization of the patient and emergency intervention if required. The problem of head injury has to be immediately evacuated if needed. While transporting, the head, neck, and body has to be in line, and a log roll has to be performed to look for secondary injuries in order to prevent further secondary neuronal injury. All this has to be done extreme carefully. Then look for irregular respiration, look for airway obstruction, and also monitor his level of consciousness. When he loses consciousness, there is risk for respiratory airway obstruction as well as aspiration. So taking all these consideration, I'll have to shift the patient for necessary investigations after stabilizing the patient.
So what's important? The patient had loss of consciousness immediately, and later he is conscious.
Patient could be in lucid interval time.
Yeah.
So that also has to be noted.
What points about towards the irregular respiratory pattern? What could be the reason?
It could be either due to the cervical spinal cord level injury, or head injury. Increase in the intracranial pressure can result in Cushing's triad, where there is hypotension, bradycardia, as well as irregular respiration. There is no bradycardia.
What are the maneuvers or methods which you take care of airway in this situation?
The head, neck, and body has to be in line. So manual inline stabilization has to be done throughout while shifting the patient as well as while intubating the patient.
Yeah.
And also a hard.
How it is done? Manual
inline by using, it can be done from the back as well as from the side. Hold the mastoid process as well as the occiput of the patient by crunching, but with both of our arms, crunch the patient's occiput as well as the mastoid, and hold it in line, stabilize it in while the patient is being intubated, and also while the patient is being shifted.
What are the other methods? What are methods of intubating without movement of a cervical spine in this situation? What are the options for endotracheal intubation?
Minimal intubation, minimal manipulation of cervical spine can be done with video laryngoscope, or also with the FOB, fiber optic bronchoscope.
What about fast track intubation? Is it a choice?
Yes, sir.
Okay. How do you? What are the indicators for imaging in a suspected cervical spine or in this situation? Which patients? Yeah.
So the patient has got. Yes, that's
number C.
Yes, sir. The patient has got a history of loss of consciousness and irregular respiration. So this could be a close head injury. So so imaging is required for further management of the patient.
What is spine board?
Spine board is a hard board in which patients suspected with cervical spine injury are transported.
What is the aim of the? How does it help?
Immobilization.
Okay.
Cervical spine as well as the spinal immobilization is got when the patient is transported using a spinal board. Keep the patient in spinal board and strap the patient so that minimum mobility is allowed.
What's the principle of log roll movement?
Log roll movement is done with multiple helpers. One should be ideally at the head end in order to support the head and neck along with the spine, and 3 other persons holding one at the leg end and 2 other supporting the body. In order to inspect the other secondary injuries, patient can be moved or patient is transported only using log roll movement.
While moving, the patient should be like a log.
Log.
Okay. So So in acute cervical spine injuries, airway compromise is very important, and respiratory support measures, intubation, and all those special precautions should be taken while head positioning as well as stabilization. And there may be associated spinal cord injuries, and care should be taken to avoid secondary spinal cord injury by your manipulation and transport. So this X-ray shows the normal alignment of the cervical spine. Okay, so this is a spine board over which the patient can be transported from the scene to the hospital, or from the hospital to for imaging and such process, but movement should be made minimal. And while airway manipulations, always you may have to remove the cervical collar, anterior part. So this is the technique of log rolling. The patients with cervical spine collar, you can see the both the legs tied together, and patient is moved as a log is turned, and with minimal aim is to minimal movement to the spine. And this is how the patient is immobilized from the scene to the hospital or to the imaging centers. So these principles should be carried out to prevent secondary spinal cord injuries in such cases, in trauma patients. Okay. So in suspected cases, the indication for cervical imaging are when there is hemodynamic instability, because cervical cord injuries can cause instability, loss of consciousness, altered mental status, craniofacial trauma, any myelopathy or radiculopathy, cervical pain, and especially if the patient complains of pain in the posterior midline, one should suspect cervical spine injury, and painful limitation of cervical spine motion. So these are all indicated for the cervical imaging in such a case. Okay, so we'll go to the next question, Safa. So this patient has been transported to the radiology department in the next floor, and CT image has been done, and you got the image. This is the image of the patient. So what do you think? What is your diagnosis, and what is the line of management? Safa. Safa, you are not all. Can you? Hello, Safa. If Safa is not audible, then Fasna may continue with it. Any technical problem with Safa? Hello.
Looks
Safa?
like
Fasna here.
Internet is not correct, I think.
I think then let Fasna can answer then. By
Yes,
the time then Fasna, please take on till Safa is online.
Yes, sir. So this is a CT showing a subdural hematoma. The primary option for the treatment is surgical evac. It is a CT showing subdural hematoma with midline shift and ventricular compression. With midline shift and ventricular compression.
Yeah, it is the midline shift is very evident. With the subdural
ventricular
hematoma
compression.
causing midline shift. Okay.
Yes.
So what's the option for treatment?
Emergency surgical evacuation using burr-hole or cranioplasty.
So what are the principles of anesthetic management in such a case, an acute subdural hematoma evacuation?
Anesthetic management after initial stabilizing the airway and circulation, there should not be further rise in the the intracranial pressure has to be reduced. The major principle of anesthetic management is to avoid a rise in intracranial pressure during the anesthetic procedures like intubation, cannulation, and transportation of the patient. And
what are the measures which you can prevent the rise of intracranial pressure during your anesthetic management?
During the stress, intubation stress response can be reduced, thereby reducing the occurrence of increase in intracranial pressure, and other pharmacological as well as positional changes can be done to keep the head in neutral position so that adequate venous drainage is allowed from the head, and pharmacological agents like intravenous mannitol, furosemide, glycerol, and hypertonic saline. All these agents are used to decrease intracranial pressure, cerebral edema, and external ventricular drainage or other mechanical methods to reduce intracranial pressure.
What will be your anesthetic induction agent of choice in this situation?
My anesthetic induction agent of choice would be thiopentone sodium, because it will reduce the cerebral metabolic rate as well as cerebral blood flow. Cerebral metabolic rate is best reduced using thiopentone sodium.
What are the problem with thiopentone sodium in this situation? Disadvantages? Patient can go for hypotension, is it not?
Hypotension in after initial stabilization. Yes.
Okay. How do you intubate? How do you intubate this patient?
Intubate the patient. So this patient is already having a suspected cervical spine injury. Over that, the patient has got head injury. So
the patient is not intubated, and this is the with this CT scan the surgeon comes to theater. What will be your what will be your relaxant of choice for intubation?
My relaxant of choice will be I will go.
Pardon? Would you use a succinylcholine or not? Or advantage and disadvantage of succinylcholine in this situation?
In the early 24 hours of trauma, succinylcholine can be used.
Yeah. What about this effect on intracranial pressure or anything?
Intracranial pressure has shown that intracranial pressure will rise to a minimum, but not of that significant level.
Will you prefer to use a succinylcholine or not?
Yes, sir, because this is a difficult intubation case where the cervical spine also has to be taken care of.
Okay, what are your can you just give some light on the principle of fluid management in such a case?
Normal saline, hypotonic solutions are preferred in head injuries in order to avoid further rise in intracranial pressure. Avoid hypotonic solutions like solutions containing the dextrose, because it has got free water after metabolization of dextrose, which will further increase ICP. And also I will avoid hypotonic solutions like ringer lactates also will be avoided.
What about glucose containing solutions? Glucose containing solutions
will be avoided.
Why?
Avoided, sir.
Why reason?
Because glucose containing solutions has got, after the dextrose will get metabolized and it will give free water to the to the circulation. This free water can increase cerebral edema.
So the indication for surgery in an acute subdural hematoma is an hematoma of thickness of more than 10 millimeters.
Normal saline.
Okay. Yes, then midline shift more than 5 millimeter on a CT scan, or acute subdural hematoma with coma with GCS like this. And what are indicate for ICP monitoring? When there is a gross shift or changes like this, you may have to go for ICP monitoring also.
Yes.
So intravenous fluid of choice is normal saline because of the osmolality, and avoid hypotonic solution to prevent cerebral edema or the rise in ICP, and better to avoid glucose containing solutions because of the poor outcome in neurosurgery, as well as the reason which Prashna has already told. Okay, I think Safa has come back.
Yes, sir. Yes,
hello, Safa.
Network issue, sir.
Safa, can you hear now?
Yes, sir.
Okay, okay. So next question will go to Safa, please.
Yes, sir.
Yeah, please see this ECG tracing, give your diagnosis and answer the questions. Safa.
Yes, sir. ECG shows U wave, so diagnosis is hypokalemia. Common causes of hypokalemia are reduced intake of potassium, then increased excretion of potassium, and redistribution of potassium from extracellular to intracellular compartment. Then the clinical features, hypokalemia can cause conduction abnormalities and arrhythmias. It can also cause myopathies, muscle weakness, then significance in anesthesia and critical care. In anesthesia, there is a chance for delayed extubation and prolonged muscle paralysis, and also it can cause intra-op arrhythmias. It can lead on to cardiac arrest. Then in critical care also it can lead on to arrhythmias. Okay, then
What the length of ICU stay and chance of extubation in mechanically ventilated patients?
Increase the length of ICU stay, and it can cause delayed extubation of the patient.
Is UVAV normally seen?
Pardon, sir?
UVAV, is it normally seen in an ECG?
No, sir.
Sure. Prominent UVAVs are diagnostic of hypokalemia. It comes after T wave.
Okay.
So another terminology is camel hum. It mimics a camel hump. The T wave and the U wave together. So, and the normal potassium value is 3.5 to 4.5. Yeah. So it can cause arrhythmias, and another problem is it can predispose the heart to digitalis toxicity. In those having digitalis, chance of digitalis induced arrhythmias are high. So the causes are decreased intake like starvation, or giving intravenous therapy without potassium containing fluids. Then drugs, metabolic alkalosis, insulin treatment therapy. Then there is a condition called pseudo hypokalemia where there is no absolute hypokalemia, but there are features, and renal loss, non-renal loss. All those can cause hypokalemia. And the clinical effects are on various systems. The cardiovascular system, Safa has told, arrhythmias, conduction defects, and myocardial dysfunction, and can cause hypotension, skeletal muscle weakness, which can be problems in the postoperative recovery for extubation, or in ICU for in mechanically ventilated patients, can cause hypoventilation in spontaneously breathing patients, and it can cause all these problems. I think with this I will hand over to Vijesh after this slide. So the treatment should be directed towards underlying cause, like withdrawal of offending drugs like diuretics, beta agonists, correct the potassium deficits, and minimizing the ongoing loss. And associated hypomagnesemia often worsens the condition. You have to treat hypomagnesemia also in these conditions. So the replacement can be, usually it is by oral, by tablet or syrup, and or intravenous. While giving intravenous for smaller dosage, you can use a peripheral line, but when you require 20 milliequivalents or more per hour, a central line is preferred, and better to have a continuous cardiac monitoring. So I think Vijesh will take over the next questions.
The next OSCE is again to Fasna. Can you identify this amplitude versus time graph, and can you just tell me what it is?
So this is a thromboelastogram with markings. A represents the reaction time, B represents the kinetics K time, C represents the slope, which is the alpha angle, and D represents the maximum amplitude of the thromboelastogram. This is a thromboelastogram showing fibrinolysis.
Yeah, most probably fibrinolysis.
Most probably.
Could you name some point of care coagulation testing that are being used?
Point of care coagulation testing include clotting time, bleeding time, activated clotting time, thromboelastogram, ROTEM. All these comes under point of coagulation test.
You can divide them as your clotting time, bleeding time, and viscoelastic tests.
Coelastic methods of
Viscoelastic, that is the ROTEM and TEG. And then you can do the platelet function analysis by sonoclot, right? So you can divide it into 3 groups. So what are the, you mentioned about thromboelastogram and ROTEM. What is this ROTEM? Can you expand ROTEM?
Rotation.
First,
Rot-
yeah. Rotational thromboelastometry, correct. And so what is the basic difference between a TEG and a ROTEM?
In TEG and ROTEM, in TEG, in the method of TEG, the cup in which the material is present rotates at a degree of 4 degree minutes. In ROTEM, the pin rotates. Instead of the cup, the pin rotates. So that is the difference in the method. And in ROTEM, 4 samples can be read at a time.
There are
where in TEG,
the thing is, in TEG, it is the cuvette. It is called a cuvette. The cuvette will rotate.
Cuvette.
The cuvette will rotate and the stationary. Whereas in the ROTEM, it is the cuvette which is stationary and the pin that rotates. And the ROTEM will give you 4 values of intem, extem, fibtem, and aptem. So I'll show some signature patterns. Can you tell Safa? Yeah,
Yes,
Safa, not first, no, Safa. The first one on the top.
First one, it is a normal thromboelastogram. Second one, it shows increased reaction time. So probably there is inadequate, means the patient might be heparinized. So protamine reversal might be inadequate. Then the third one shows hypocoagulability. Then the fourth one.
Why the third one shows hypo? You should tell me why. Safa?
Yes, sir.
What is happening there?
The maximum amplitude is low. That is, the platelet number or function might be affected. So we can treat it with platelet transfusion. Then the fourth one is already told, fibrinolysis. Then the fifth one is hypercoagulable state. So probably treated with anticoagulants.
So correct. So all of them are right. So suppose you have a high or you have a low angle as shown in the third picture. What will you give? The alpha angle is low, right?
Yes, sir.
The third picture. What would you give? Of course, you said you will give platelets. What about if the alpha angle?
Cryoprecipitate can be given.
Cryoprecipitate can be given. So these are just some charts. I'll be sharing this with all of you. So you can just go through this and know what to be given at what time. So the next OSCE is on laparoscopy. To Fasna, what is the rate of creation of pneumoperitoneum and what are the pressure limits set? And why do we set this pressure limit?
The rate of creation of pneumoperitoneum is up to 3 liter per minute. It starts from 1 and gradually up to 3 to 4 liter per minute, the initial insufflation, followed by a maintenance insufflation, which is in a range of 200 to 400 ml per minute. The limit of the pressure limit is the intra-abdominal pressure of 10 to 15 millimeters of mercury. The limit is set because higher increase in intra-abdominal pressure can cause other hemodynamic issues in the patient, like by compression of the major vessels and hypotension and decreased cardiac output. All these will be exaggerated with higher pressures.
To insufflate very fast, what would happen?
If we insufflate air, carbon dioxide very fast, that can lead to sudden stretching of the peritoneal receptors and cause vagal stimulation, which will result in bradycardia and other arrhythmias.
What are the cardiovascular changes? As you said, you have started it off. Can you explain those cardiovascular changes that happen during laparoscopy or the pneumoperitoneum and the pneumoperitoneum?
When the pneumoperitoneum is created, initially there is, because of the increase in the intrathoracic pressure, initially there is an increase in venous return and thereby a cardiac output rise, followed by the compression of the vessels will reduce the venous return and thereby decreasing the venous return, decreasing the cardiac output, and also increasing the systemic vascular resistance. And also there's a surge of neurohumoral endocrine response, thereby catecholamines released can also further increase the systemic vascular resistance, and thereby can show a increased blood pressure and heart rate.
And of course, the workload on the heart is also going to be increased, right? So these are the various that take place not only in the cardiovascular system, even in the respiratory system, the renal system, all of them are affected. And we'll forget this one. I'll give you a small scenario. 69-year-old female with primary biliary cirrhosis. She's undergoing laparoscopic cholecystectomy. Anesthesia was induced with fentanyl, propofol, rocuronium, and maintained with sevoflurane after intubation with a 7-size DT tube. Now, abdomen was entered under direct vision with a 5 mm OptiView trocar. Pneumoperitoneum was achieved with carbon dioxide insufflation and maintained at a pressure of 15 mm mercury. A second trocar was then placed in the umbilical region. At this time, the monitors showed a sudden drop in the EtCO2 from 40 to 7. Hypotension and hypoxia followed. BP was 70/40. The saturation came down to 75. So based on this history, and the waveform is shown there, what would be the differential diagnosis? Pasna.
The hemodynamic parameters show hypotension as well as desaturation, and also a sharp drop in the end-tidal carbon dioxide. In a laparoscopic procedure points to venous air embolism in the patient.
Yeah, it could be air embolism you are suspecting. It. Could it be a pneumothorax?
It could be a pneumothorax, yes.
Could it be a positional change in the endotracheal tube, or you could have come out?
It could accidental extubation.
Some different diagnosis. So if the scenario is given, you can just put up some.
It could be disconnections at various levels of the circuit.
Mechanical error, correct, absolutely right. So the differential diagnosis is over. Now, what are this? Why does this air embolism? This could be air embolism, right? It could be the carbon dioxide embolism. Okay. So, what are the causes during laparoscopy? Why does it occur during laparoscopy?
Accidental puncture of the vessels, and presence of nitrous oxide that we keep. Even a small air can increase in size within the presence of nitrous oxide.
What we are calculating is carbon dioxide, not air. The effect of nitrous oxide on carbon dioxide is not that much, right? Not that much on, because it is more soluble, right?
Soluble in water, blood.
Yeah. It could be, as you said, it could be because of the varus needle directly into a vein, or it could be some injured vessels that are open, and liver parenchyma could have been dissected, right? So these are the causes under laparoscopy. Now, how will you confirm this diagnosis?
Clinically, with the immediate monitors, you can use a drop in the end-tidal carbon dioxide, saturation fall, BP, hypotension, and also specifically using a transesophageal echography, even a 0.02 ml per kilogram of air can be detected using transesophageal echo, which is the most common method, most sensitive method. And then precordial Doppler, yes, we'll have to go and
you have to go and get one, no, because it will not be there in the theater where laparoscopy is being. So it will take time. So what you can do, can you auscultate?
Yes, sir. If you auscultate in the cardiovascular system, Mills wheel murmur can be heard.
Murmur. Yeah, good. So you have already said the signs and symptoms. Now, Safa, can you tell how you will manage this patient?
Yes, first of all, inform the surgeon and ask him to stop with the surgery. Then
Good.
reposition the patient. Laparoscopy, reposition the patient to make it 100% FiO2 to 100%. Then put the patient in the left lateral position with the head tilted downwards. Then hello.
What is it called? What position called?
Durance position.
Yeah, correct. Yeah. Continue.
Then also we have to then try aspirating the air through the central venous cannula. Means put a central venous cannula and try aspirating it.
Correct.
And if there are any visible vessels open, then we can try clamping those vessels.
Fine, that's right. Anything else?
And in skull surgeries and all, it's difficult. We can flush the area with fluids.
And if finally, if you can do a hyperbaric oxygen therapy also, right? So this is a picture of how the air looks on a TE. And these are just what Safa has said, almost everything she has mentioned. And how will you prevent this? As an anesthesiologist, what can you do? Because this is a surgical complication, right?
Yes, sir. The first one is the presence, the ASA1 monitoring by the anesthesiologist, presence of the anesthesiologist in the theater, and examining the site of surgery, and just means inspect for any visible gas molecules getting absorbed into the vasculature. Then if we can avoid surgeries in sitting position, because sitting position surgeries are most prone for venous air embolism. So if we can prefer for other positions, then go for that. Then
Laparoscopy specifically. This is this case.
Then decrease the rate of rate of insufflation of carbon dioxide should be up to the standards.
So it is our role to ensure that the surgical team is adhering to low insufflation pressures. You should maintain adequate hydration, give adequate PEEP so that the venous pressures are high, and Trendelenburg positioning. Very good. Fine. So the last one on this set is again a case history to Fasna, a 23-year-old woman, lady who is with a history of chronic cholecystitis is scheduled to undergo laparoscopic cholecystectomy. She has no reported history of anesthetic complications. She is induced with propofol, rocuronium, and maintained with sevoflurane after tracheal intubation and fentanyl. So while the patient is being prepared for surgery, ETCO2 rises to 55 millimeter mercury over a period of 5 minutes. Esophageal temperature rises from 36 to 39 over the same time interval. What would be your differential diagnosis based on this history and findings?
Differential diagnosis will be malignant hyperthermia, thyroid storm, pheochromocytoma, neuroleptic malignant syndrome.
Yeah, that's right. So most probably this could be
malignant hyperthermia.
What are the triggering agents?
Halogenated volatile anesthetic agents and succinylcholine.
Right. What are the signs of malignant hyperthermia?
There can be early signs as well as late signs. Early sign can be initially seen as a masseter spasm, then generalized muscular rigidity, followed by tachycardia and hypoxia, hypercapnia. And then towards late signs like hyperthermia can occur, then rhabdomyolysis, cardiovascular collapse.
Yeah, right. Okay, Safa.
Yes, sir.
Do you know of any scoring system that is available to suggest that this patient has malignant hyperthermia?
Larax clinical grading system. The maximum scoring is 50. If it is above 50, it's almost diagnostic of malignant hyperthermia. In that we look we grade the clinical features, muscular rigidity, masseter spasm, many parameters.
It's a main large scoring system. Way back in 1990s, it was proposed. And what is the drug of choice that is given during this
Drug
attack?
of choice is dantrolene sodium, 2.5 mg per kg.
Maximum dose?
Up to 10 mg.
So if there is no response after 10 milligrams per kilogram, the outcome is unlikely to be good. Okay. Now, regarding your in vitro contracture test, which is supposed to be the diagnostic test, when do you do it and what is done in it?
If there is a suspicion of malignant hyperthermia in a patient, then after 3 months of the attack, we take a muscle biopsy from the vastus lateralis of the patient, and we divide it into strips, and we look for the viability, and we expose the we expose the muscle biopsy specimens to caffeine or halothane. And if it shows a more than normal contracture, it is diagnostic of malignant hyperthermia.
So these are the differential diagnosis. It could be mechanical, anesthetic, surgical, and the triggers and safe drugs. And as Fasna said, there are early and late signs. And this is the Larax scoring system. Study it. Anyway, if there is the score of more than 50, you're almost certain that the patient has developed malignant hyperthermia. And dantrolene is the drug which acts on the excitation, contraction, coupling mechanism. And muscle biopsy, again, it is done at specialized centers. And this is how it looks like. You will have a sustained contracture as shown in the figure B. So over to Mubarak sir. Mubarak sir, you can share. Sir, you're muted.
Okay. I will go to my 10th question. I think Fasna will answer. So this is the question. Just please read out and answer. Fasna?
So slide share.
Yeah.
Sir, it's not visible. Please share the slide, sir.
Not visible?
Not visible. Please share the slide.
Okay. Is it okay now? Is it okay now?
Yes, sir. Yes, sir. Now visible.
Yeah.
Yes, sir.
Sorry for the interruption. Okay.
Yes, sir.
Okay. Fasna, please.
Which group of drug this belong to? This belongs to non-depolarizing muscle relaxant aminosteroid group, Rocuronium. The uses and dosage. The uses of Rocuronium, it can be used as this is used as a muscle relaxant in rapid sequence induction, and also and in places where succinylcholine is contraindicated.
A better terminology will be neuromuscular blocking drug rather than muscle relaxant. Okay.
Yes, sir. Neuromuscular blocking drug. The dosage varies with the range from 0.6 to 1.2 milligram per kilogram. At 1.2 milligram per kilogram, excellent intubation condition is got at 60 seconds, similar to succinylcholine. The two advantages and two disadvantages. The two advantages is that Rocuronium polypharmacy can be reduced because it can be used as the induction in the initial induction as well as maintenance drug Rocuronium can be used. Advantages, then excellent intubation condition at 1.2 milligram per kilogram. The two disadvantages, it is a long-acting muscle relaxant, so it will be difficult when you use in a difficult airway situation. And also, it cannot be used in patients with hepatic dysfunction. The specific antagonist of Rocuronium is Sugammadex. And primary route of excretion, 75% of Rocuronium is eliminated via bile and 25% is excreted via renal.
So, okay, it's an aminosteroid neuromuscular blocking non-depolarizing drug, which can be used for standard as well as rapid sequence endotracheal intubation, the dose which she has told, and it is primarily excreted by liver. So, I'll go to the next question. Question 11 to Safa.
Okay, sir.
So, Safa, this is a question from the history of anesthesia. And
Yes,
one of my postgraduate teachers used to tell, you should learn these inscriptions by heart, each anesthesiologist. So that's why I put this question.
Yes, sir.
Okay, Safa, can you just answer
So,
this question?
so Morton's, WTG Morton's Tom. So WTG Morton's tombstone.
Okay, it is Morton's tombstone. Okay, what is his contribution to anesthesia, Morton?
Yes, he was responsible for the first public demonstration of either anesthesia on October 16, 1846 at Massachusetts General Hospital for a patient with neck tumor.
First success.
First successful.
So first successful public demonstration of either anesthesia. Okay. What is the inscription written and where the inscriptions are written? How it is written? Any idea? Over the tombstone. And who has written this? By and the inscriptions are contribution by whom?
So before whom surgery was agony, like that.
So that is Morton's tomb, and he was a Boston dentist, and the monument reads towards the inscriptions are written all over the four sides of the tombstone. So the one facing towards the east reads W.T.G. Morton, inventor and revealer of anesthetic inhalation, born 9th August 1819, died July. That is on the eastern side, and the other side, before whom in all times surgery was agony, by whom pain in surgery was averted and annulled, since whom science has control of pain. That is on the four sides of the tombstones. These are the inscriptions written on Morton tombstone. Okay, just for interesting from the history part. Okay. So the last question from this round goes to Fasna. Please identify the device and give two indications, advantages and disadvantages.
This is a flexometallic tube. Two indications. Flexometallic tubes are used.
One second. There are so many names for that. Synonymous names. Please mention a few synonymous
reinforced
names.
Tubes, armored tubes.
Okay. Anode tube. Okay. Okay. Continue. First now.
The two indications are these flexometallic tubes are used in procedures which require prone position, and also in surgeries which require head and neck, which involves head and neck surgeries.
What is the principle behind using that tube? Why do you want to use that tube?
Because it is kink proof. It will not kink, bite resistant.
Yeah.
And
there is chance of kinking. Yeah.
There are chances of kinking and biting.
Or the surgeon taking sutures over the tube.
Yes, sir.
Okay. Then
disadvantages. The disadvantage is that You require a stillet for its insertion. So stillet related trauma will be there, and also it is difficult to be introduced in a difficult airway situation.
Okay.
Skill is required to introduce it.
Yeah, you required stillet and Magill's forceps, no?
Sir.
So it is resistant to kinking and compression and
kinking
or
airway obstruction.
And the problems are with using stillets and Magill forces together. So I think I will hand over to Vijesh and yeah, for the and by meantime it's 8 o'clock, so we'll take the permission of the organizers for the continuation also, please.
Yeah, please continue, sir. Please continue.
Okay, then next we'll share to Vijesh. I'll stop share. Vijesh, you can. Any problem?
Slides are visible. Vijay sir, please.
Vijesh is
Am
not
I audible?
Yeah, now you are audible. Dr. Vijesh is not audible now.
Now it's audible, sir. He can speak. He's trying to share his slides.
Okay. I'm audible right now? Yeah.
Yes,
okay.
Yes.
So the next OSCE will be on defibrillators. So first question would be to Dr. Fasna. What are the types of defibrillators that you know about?
Monophasic as well as biphasic defibrillators, and internal, external defibrillators.
What about transvenous?
Transvenous, AICD, automatic internal cardiac defibrillator.
Yeah, transvenous. So you have an internal, external, and transvenous.
Transvenous.
So what is the difference? What is the difference between cardioversion and defibrillation? Fasna, yeah.
Sir?
Can you tell me what is the difference between cardioversion and defibrillation?
Defibrillation is an emergency life-saving procedure. Cardioversion is probably an elective, semi-emergent procedure in which defibrillation, it is unsynchronized. In cardioversion, you give the shock synchronized on R wave. And the dosage, the joule is given in a graded fashion in cardioversion, but in defibrillator, the highest possible joule is given initially. Then higher joules are used in defibrillation, lower joules are used in cardioversion. It is used in pulseless ventricular tachycardia and ventricular fibrillation, defibrillation. Cardioversion is used for other tachyarrhythmias to convert into sinus rhythm.
Right. Since lesser joules are used, you have less damage to the myocardium. And since this is a planned procedure, it is usually given, it is delayed. So during that time, you have to give anticoagulation to the patient, because if suppose it is for atrial fibrillation. So it's a planned procedure. So it will be, you'll have to give anticoagulation. And in defibrillation, there is no delay. It is an emergency. So mainly for ventricular fibrillation. The next question to Safa, right? Safa, can you tell me the difference between monophasic and biphasic defibrillators?
In monophasic defibrillators, the electric current travels from electrode placed on one part of the chest, 2 electrode placed on the other part of the chest. But in biphasic, the current travels back also. From there is a to and fro movement of current. So there is
Right.
less chance of injuries and less current joule is required for biphasic.
Okay. And the first shock efficacy is higher in biphasic. Since the shock is less, there are less skin burns and myocardial damage. The machines, biphasic machines, are lighter and smaller. And just for knowing, the monophasic waveform is a dampened sinusoidal waveform, which is known as the Lown-Berkowitz waveform. Whereas in the biphasic, it is the biphasic truncated exponential waveform. And in biphasic, there is an automatic measurement of transthoracic impedance in the newer machines. Whereas in monophasic, there is no such thing. Okay, so these are the basic differences between monophasic and biphasic. Now to Fastna. So this is the waveform. What are the different types of devices, the implantable electrical devices that you know of? Different types of IEDs. Can you name a few IEDs? Very good. Pacemaker. You just now mentioned, no?
Automate AICD.
Good.
AICD, automated internal cardiac defibrillator.
Automated implantable cardioverter defibrillator. Okay.
Implanter.
Then, so these are the 4 different IEDs that are available. That is your permanent pacemaker, the AICD, and then you have something called the cardiac resynchronization therapy, the CRT. And if it has a defibrillator, it's called CRTD. And nowadays you have what is the implantable pulmonary artery pressure monitoring system, that is for managing heart failure. So these are the 4 different types of IEDs that are available. This is from the Indian Journal of Anesthesia. So what is the role of magnet? You know, we always hear, no, you keep magnet. What does this magnet do on a pacemaker or on a AICD? So these are the 2 things that we use where we keep a magnet, right? What is the role of magnet?
Magnet will convert the device into asynchronous
Very
mode.
good. Magnet will convert the pacemaker into asynchronous mode.
Pacemaker.
So a magnet is used to suspend anti-tachyarrhythmia functions of an AICD or to produce asynchronous pacing in a permanent pacemaker. So when a magnet is applied on a permanent pacemaker, asynchronous pacing will be initiated. And when it is applied on an AICD, the anti-tachyarrhythmia detection is suspended, but pacing is not suspended. So what it does is, you can just have a look at the picture there. It is a reed switch. You can see there is a reed switch. Reed switch is, it is a glass and inside there will be 2 paddles. And when they touch, putting the switch on and off is possible with an external magnet. The circuitry is such that switching on makes the sensing function null and void. It functions in an asynchronous mode. So pacemaker is converted to mandatory pacing mode. Okay, so all sensing issues are removed. So this is how it functions. Okay. So the next one, Safa, can you identify what this is?
Yes, this is a form of HFNO. Thrive means transnasal. HFNC.
What is it, HFNC?
High frequency nasal cannula. High frequency nasal oxygenation.
Is it frequency?
High flow.
High flow. Okay.
High flow.
Can you tell the full form of this acronym?
Thrive is transnasal, humidified, rapid insufflation, ventilatory exchange.
Good. Next to Fastna. What is the mechanism of this machine? How does this work?
The HFNO delivers oxygen at a very high flow of around 40 to 70 liters per minute. And also the delivered oxygen flow is heated as well as humidified thereby preventing the crustaceans of the secretions. And also an automatic PEEP is produced because of this high flow, thereby splinting the alveoli, preventing the collapse of the diseased alveoli.
Correct. Thank you.
So oxygenation occurs, heat and humidification occurs, and also carbon dioxide exchange is also, it prevents the buildup of carbon dioxide in the alveoli because ventilatory exchange is also occurring.
Along with the mechanism, we have also told about the advantages. So the next question is invalid. Okay. So how much is the PEEP developed, Safa?
For every 10 liters of oxygen, 1 millimeter mercury PEEP is developed.
Okay, for every 10 liters, right? So next, what is ROX score?
ROX score, it is a score used to identify whether the patient on HFNO requires intubation or not. There is a formula, FiO2 by oxygen saturation whole divided by respiratory rate. If it is more than 4, then the patient does not need intubation. Then
4.88.
4.8.
Yeah, that's it. So the mechanism is it gives a precise oxygen delivery, gives the functional residual capacity is enhanced, and there is a dead space washout. It's all these mechanisms have been explained by Fasna. And you can explain the advantages of this machine by using this mnemonic high flow. It is heated and humidified. The inspiratory demands are better met. The functional residual capacity is increased. It's very lighter and easily tolerable, and the oxygen dilution is prevented, and there is washout of dead space. The PEEP developed again for every 10 liters, around 0.9 centimeters of water is the PEEP that is developed if the mouth is closed. But if the mouth is open, it is only 0.35 centimeters of water. ROX index, again, as Safa said, it is the ratio of saturation by FiO2 to the respiratory rate. And if it is more than 4.88, patients are less likely to be intubated. So that is the importance of ROX index while the patients are. So what it does, it is avoids the delay in instituting mechanical ventilation. The next one, the last one in this is to Fasna. Can you, this is a ultrasound image where a block is going to be given. Can you identify what type of block will be given here from this anatomy? Fasna.
Erector spinae block. Sir, erector spinae block.
Erector spinae plain block. ESP block, right?
Plain block.
Good.
SP. Sir.
So next question to Safa. What are the chest wall facial plain blocks that you know about?
So,
A few of them.
serratus anterior plain block.
Yeah.
Then a tap block.
Good.
Then a paravertebral block.
Okay. So these are the various plain blocks that you can give. The pec blocks, the pec blocks you can give rector spinae, serratus anterior plane. Okay, so these are the various facial plane blocks, and this is a diagram where you can the different facial planes are shown. The next one would be, what are the indications for a erector spinae plane block?
Indications, rib fracture, analgesia for rib fracture, then analgesia for surgeries of the chest wall and back, then for lung surgeries also, after a long thoracic incisions, patient can get analgesia. Patient can be given analgesia with erector spinae blocks.
Where is this local anesthetic deposited in erector spinae plane block?
It is deposited between the erector spinae muscle and the transverse process.
What is the difference between a lumbar and thoracic level ESP? I mean, erector spinae plane block.
in the thoracic level, the three major muscle layers that we can visualize are rhomboids major, then trapezius, trapezoid, rhomboid, and erectus spina. In the lumbar region, the rhomboids will not be visible. Only trapezius means only.
Only the trapezius spina will
and
be
erectus
there.
spina.
And what is the usage of your transducer? Is it different?
Transducer, above we use linear and below curvy linear. Lumbar.
Yeah, because of the depth is required in the lumbar area. Okay, now Fasna, can you tell the classical USG appearance of lamina, transverse process, and articular process? How will you see it on the ultrasound?
On the ultrasound, transverse process seen as a trident sign. In lamina, it is seen as sawtoothed sign, and for camel hump.
Articular process. So this is how it's seen. If you look at the picture, you can see here the three arms. This is the three arms of the
cam,
and this is the camel hump, and this is the sawtooth appearance of the lamina. Very good. And what are the newer blocks that are available now for giving analgesia for your knee joint and your hip joints? The newer blocks on the newer analgesia blocks that are available.
IPAC, interspace between popliteal artery and capsule of knee. Anesthesia can be, a local anesthetic agent can be given in the space between the popliteal artery, behind the popliteal artery and in front of the capsule of the knee. This can provide postoperative analgesia in ACL repair, total knee replacement, and other knee surgeries. And that is for the knee joint. For the hip joint, PENG block.
What is it? What is PENG? What is it?
Nerve group. Pericapsular nerve group block.
Thank you, sir. Sir, over to you.
Shall I continue? Okay.
Please, sir, please continue, sir.
Okay, thank you. So my next question, so far we have not reached any question regarding COVID-19 in this scenario. So I thought I'll put a COVID question to Fasna. Can you just enumerate the precautions while managing the airway of a COVID-19 patient? Almost all the clues are given in the picture itself. Please enumerate it. Fasna? Am I not audible? Okay.
The precautions during airway management in COVID-19. Yes, sir.
Yeah.
Yes, sir.
Yeah, please.
COVID-19 include patient safety as well as the safety of the patient airway management specialist.
Operator safety and patient safety measures. Better to classify
in that manner. The patient ourselves has to be protected by the use of.
Hello, your voice has been broken. Fasna, you are not audible. Can Safa take over if Fasna is not audible?
Yes, sir. The operator safety, the operator should be wearing, first of all, there should be only minimum number of means operators in the theater. Then the operator should be wearing personal protective equipment with N95 mask. Then the operating setup should be a negative pressure operation theater with all the with only the minimum required amount of objects in the theater. And regarding the patient side, It should be a rapid sequence induction and intubation, and with the avoidance of positive pressure ventilation, and with the help of a video laryngoscope. Then regarding the circuit,
how does a video laryngoscope help?
Video laryngoscope, it can give a better view of the glottic aperture, and intubation can be made quicker.
Yeah, it provides both the operator safety as well as patient safety.
Patient
better.
safety.
Operator can be away from the patient with a better visualization, causing a better successful intubation. Okay.
The usage of heat moisture exchanger with viral filters are highly advised. Then the use of aerosol boxes, even though controversial, can help the spread of the virus. Then regarding extubation, the prevention of prevention of cough during extubation by making the extubation under deep plane can also prevent bucking and the aerosol spread in the theater. Then
okay, so you have enumerated many. So first and foremost is most experienced person to perform the intubation available. That will be the best thing. And endotracheal tube is preferred over supraglottic airways for obvious reasons. Use PPE. Most of them we have told. Negative pressure operating room. Disposable airway equipment whenever possible. Minimize the number of personnel. Optimize positioning. Good pre-oxygenation with a tight-fitting mask. And then rapid sequence induction. Type of laryngoscope. Most comfortable is the best always.
yes,
Then inflate the cuff before connecting the breathing circuit. Use ETCO2 as far as possible. Avoid auscultation with your conventional stethoscope to protect yourself. Almost and give prophylaxis for vomiting and coughing before extubation. That's also important. I think I will go to the next question to Fasna. Fasna has come back. Okay, Fasna, please. Please read out this.
Yes, sir. Adult male for excision of thyroglossal cyst, lap cholecystectomy under general anesthesia 1 year ago. He is a non-smoker with social alcohol use, a heart rate of 88 per minute, BP 140/90 millimeters of mercury, respiratory rate of 14 per minute. AST level is 65 international units per liter and ALT is 55 international units per liter. Enumerate the predictors of surgical outcomes.
Please stop a moment. What are the features you get in this from the history? What are the positive anesthetic implications in this history? Hello, Fasna, please.
The patient has, yes, sir. The patient has undergone a surgery under general anesthesia 1 year ago. Then the patient has
now
got
a
marginal rise.
Okay. Now presenting for repeat general anesthesia. Okay.
Repeat general anesthesia. So
okay.
Second exposure of general anesthesia. Then the patient has got a marginal rise in the AST, ALT level, a marginal rise, and also patient is a social alcoholics, not an alcoholic, but a social alcohol user.
Okay, please go on to the questions. Okay.
Enumerate the predictors of surgical outcomes.
Yeah. In this patient.
The patient can. The patient will have probably a favorable surgical outcome.
Yeah.
Hello, sir, am I audible?
Yeah, you are audible. Continue.
Sir,
you are audible.
A favorable surgical outcome is expected. A favorable surgical outcome is expected in the patient because there is no much of liver enzyme differences, variations, or a rise. We expect a favorable outcome, sir. The scoring system is commonly used for assessment as Child-Turcotte-Pook score. And here the patient will come under Child-Turcotte-Pook A, which is the least, which comes under very less risk of mortality. And do you accept this patient for the planned procedure? Yes, I will accept the patient, provided I will monitor for the post-operative liver function test, and also the clinical condition of the patient will be reassessed post-procedure. What are the contraindications for elective surgery? Generally for liver disease of acute hepatitis, fulminant hepatic failure, end-stage renal liver disease, and child PUG category C are contraindications for elective surgery.
So this patient has got a marginal increase in the liver enzymes. What is its significance? What does it mean?
It is only a marginal rise in liver enzyme. So
Do you need a repeat
it does
LFTs?
not.
And
I
he
would
uses
prefer to
alcohol
get
occasionally. He's an occasional alcohol user.
Occasional only.
Yeah. And he has undergone a general anesthesia 1 year back. Now coming
1
for
year
a
ago.
yeah.
So there can be repeated exposure of general anesthetic hepatotoxic drugs. So intraoperatively, I will avoid hepatotoxic drugs, avoid hypotension, hypoxia, hypercapnia, and retraction on the liver. This is a thyroglossus surgery. And
This patient can almost be regarded as a normal, healthy patient because
yes,
a social once in a while an alcohol use does not produce any problems.
no.
And the history of general anesthesia 1 year back, after he didn't have any problems afterwards.
No.
And a marginal increase in the liver enzymes can be a normal in 1 in 700 or so patient. Normal patients can have.
Yes.
So, but
yes, sir.
Having these problems, you should take him as a child score A and take all the precautions.
Category A.
Yeah, to precautions to
avoid
prevent
further hepatic injury,
hepatic damage or hepatotoxic, and take all precautions to ensure hepatic perfusion intraoperative
for favorable outcome.
Okay. So these are the other scoring systems are MELD score and all for liver advanced liver disease.
Score.
So the predictors of surgical outcome in liver disease patients are coexisting medical diseases, types of surgery, upper abdominal surgery, emergency surgery carries higher risk, presence of ascites, raised serum creatinine, preoperative GI bleed, high ASA status, history of previous abdominal surgery, existing steatosis, then the use of the hepatotoxic drugs or procedures, and the hepatic blood flow, perioperative hepatic maintenance of hepatic perfusion. These are the predictors the patient will have a good or poor outcome. So the child PUG classification, all of you will be knowing, and the MELD score is for end-stage liver disease, mainly for liver transplant. Is a common scoring systems used, commonly asked for the exams for postgraduates and all. It's very important. Then the liver function test, abnormal LFTs can exist in 1 in 700 normal patients. So LFT does not measure the hepatic function, but it measures the release of damaged enzymes from the damaged or dead cells. And INR is the most sensitive indicator of hepatocellular dysfunction. And asymptomatic transaminases below twice normal may undergo anesthesia and surgery without any problems. These are the standard recommendations. And one should not undertake surgery when there is acute viral hepatitis or alcoholic hepatitis, fulminant hepatitis, and end-stage disease, liver diseases. On this. So I'm not going to details. There is a flow chart regarding the AST, ALT elevations regarding abdominal liver functions due to this. So I'll wind up with the next question, 15th question. Fasna, Safa will answer.
Yes, sir. Yes, sir. This is a BIS monitoring device. One is the BIS monitor, two the BIS electrodes, three the EEG waveform, and four is the BIS value, present BIS value. And it is used to monitor the depth of anesthesia or awareness under anesthesia. It can also be used to titrate the dose of anesthetic drugs so that the inadvertent means we can prevent overdosing of the patient, and we can prevent post-operative nausea, vomiting, delayed extubation, all. Then the target value for general anesthesia is 40 to 60. Then 60 to 80 is sedation, and 80 to 100 is an awake patient. Then name two anesthetic drugs which can cause false values. Administration of ketamine Then nitrous oxide or can cause false values.
So BIS monitoring is not only for the awareness to adjust or titrate the depth of anesthesia, or even monitors and anesthesia care also you can use BIS monitor to adjust your required depth of sedation also. So this is the BIS monitor, and use the real-time ECG, and the value is derived from the algorithm interpreting the EEG data from the machine. And BIS value ranges from 0 to 100, and 0 represents persistently suppressed EEG activity, and 100 indicates a fully awake stage. So in the general anesthesia, we target a 40 to 60 range to have a moderate depth of anesthesia with low intraoperative awareness. And some drugs, anesthetic drugs, can have a falsely elevated value. The nitrous oxide can give falsely elevated BIS values, and the ketamine can cause also can cause elevated BIS values. So this is a BIS chart, and I think by this 15 questions I will wind up for the day and hand over to Dr. Vijish and the organizers.
Just one question. What are the methods of lung isolation that you know about? Safa.
The methods of lung isolation are insertion of double lumen tubes, then endobronchial tubes, and bronchial blockers.
Yeah, good. Can you define margin of safety?
Margin of safety is the length of the tracheobronchial tree through which an airway can be moved without obstructing a major airway.
Conducting airway.
Major conducting airway.
So, in which side it is more, left or right?
Margin of safety is more in left side. In right side, due to the rapid uptake of takeoff of right upper lobe bronchus, the margin of safety is only around 0.5 centimeter. On the left side, it is around 2 centimeter.
Left it is more than that. So since it is more on the left side, we always prefer to put left-sided double lumen tubes. Yeah. So first, now, can you tell me a few indications where you will put only a right-sided double lumen tube? Exclusively, you would like to put a right-sided double lumen tube. First, now.
Left-sided pneumonectomy, left main stem.
Left-sided pneumonectomy.
Okay. Left-sided pneumonectomy, left-sided left-sided mainstem bronchial tumors, left-sided bronchopleural fistula.
So that is the one, the left-sided intraluminal bronchial tumor, where you cannot put a left-sided DL. You'll have to go for. But in a left pneumonia, you can put a left-sided DLT and pull it up. You can pull it up. When the
left-sided tube.
The idea exclusively it is done when you have an intraluminal tumor in the
in the mainstem bronchus.
So how will you size the DLT, Safa?
Sizing of the DLT depends on the conventional method is depends on the gender and height of the patient. For a female patient who's less than 160, 35 French, more than 160, 37 French. For a male patient less than 170, 39 French, and more than 170, 41 French. The newer method is to take a chest X-ray and chest X-ray PA view and measure the width of trachea at the level of clavicle. If it is more than 1.8 millimeter, then more than 1.8 millimeter, 41, then 16, 15, 14, 39, 37, and 35.
It is 18 millimeters or 1.8 centimeter.
Centimeter.
Okay.
Also, bronchial diameter 2 centimeters from the carina.
Yeah, fine. What I would like to ask you is, suppose there is a special situation, like in case of your pediatric patients. First now, in pediatric patients, can a double lumen tube be put in? Very small children, around 3 years, 2 years, or any special tubes are available?
Bronchial blockers can be used.
Yes, bronchial blockers can be used. Okay. Any tubes, any special tubes are available?
Mararo.
Marrar.
Yeah, Mararo tubes, correct. So Mararo tubes, the one that is shown on the left side, is available for pediatric patients. And then what about for tracheostomy patients? Special
Tracheopart.
situation. Tracheopart, that is a disposable one, and Naruke and double lumen tube is also available, where you can insert it through the tracheostomy. Now, what is the role of ultrasound in finding out lung isolation? Because nowadays ultrasound is in vogue. So can you enumerate the use of ultrasound in isolating the lung? Safa.
In a ventilated lung, the lung sliding sign will be positive. So in a non-ventilated lung, the lung sliding sign will not be there, and also the lung pulse sign, which is the cardiogenic oscillations on the lung. Collapsed lung will be there. So absent lung sliding sign with the presence of lung pulse shows isolation.
Lung pulse is 93% sensitive and 100% specific for identification of lung collapse. That is the one sign, lung pulse sign. Okay, thus if lung sliding is absent on one side and lung pulse is seen on the other side on an ultrasound, that means you have got adequate functional lung isolation. Okay.
Yes.
Now, Fasna, can you tell me what you will do when suppose the patient develops a hypoxia during one lung ventilation?
Treatment of hypoxia during one lung ventilation, I will convert the FiO2 to 1, giving 100% oxygen. And if there is precipitous fall, I will convert it into 2 lung ventilation. If not, step by step, I will, after giving 100% oxygen, I will cut off the inhalation agent so that the hemodynamics is stabilized. And also CPAP will be given to the non-ventilated lung, and a positive end expiratory pressure PEEP will be given to the ventilated lung. Then after other pharmacological agents like almetrine can be tried, and then even at last inhaled nitric oxide can be given. And even then, if it is not saturation is not picking up, I will partially clamp the pulmonary artery. The surgeon will clamp the pulmonary artery and then convert it into 2 lung ventilation.
Correct. So these are the various steps that you can take. The first, the treatable causes should be done first, right? You should see whether the DLT position is correct, whether there are secretions, blood, all that, and whether your hemodynamics are gone wrong. So you should correct all that. And then you optimize your ventilation and optimize perfusion. And finally, if nothing works, you have to ask the surgeon to stop the surgery. Yes, and again, you can even go in for NOVA lung or an ECMO if the patient is deteriorating. Okay. Next OSCE is which gas law forbids you from putting the gas cylinders in the sun, and why? Fasna.
Gay-Lussac's law says that as the temperature increases, the pressure built up in the cylinder will rise where the volume is kept constant. This can lead to explosion of the cylinder.
So for 1 ml of liquid oxygen will give you
860.
How much? 860?
860 liters of gaseous oxygen.
Gaseous oxygen. Which gas law is
Venturi's principle. For doing petics test, we connect the vein circuit to the machine, then occlude the patient and close the APL valve, and pressurize the circuit, and then open the release the occlusion on the patient end and activate the oxygen flush. Due to the high flow of gas oxygen from the inner tube to the outer tube, there occurs a area of negative pressure which sucks the gas in the ventilating bag, and thus the bag collapses. This is due to Venturi effect.
Pointing effect, Fasna.
Pointing effect is seen in the where the nitrous oxide and oxygen. Nitrous oxide is in the liquid form and oxygen is in the gaseous form. So the critical temperature of the NOx cylinder is reduced when compared to the individual critical temperatures.
Correct. So the thing is, in cold temperatures, what will happen? In cold climate, where the temperature is less than -6 degrees, the nitrous oxide will separate into a liquid and it will remain the bottom of the cylinder. And if you don't shake, correct, so you will get initially the patient will get only oxygen, and later on will be getting only nitrous oxide and develop hypoxia. Fine, with this we'll end the OSCE because it is getting too late. We were supposed to finish at 8 o'clock anyway. I wish to congratulate both of you for putting up a good performance, and would like to thank Bharat sir for the and the presentation to present these topics. And over to Binil.
Thank you, sir. Now we can take some questions from our seniors. So many seniors are sitting here. They are participating with us. If they have any questions, or then we can take the questions.
We have Professor Madhusudan Upadhyaya, who is going to be the next faculty for the next class on 26th December also.
Madhusudan sir, if you are present, please. If there is no questions, I got one announcement. Our next program will be held on 26th December, Saturday at 6 p.m. And we have 3 topics for next week. The first one is uptake and distribution of inhalational agents by Dr. Madhusudan Upadhyaya, Professor, former HOD of KMC Mangalore, Department of Anesthesiology, Kasturba Medical College, Mangalore. And the second topic is inhalational agents by Dr. Sanish PJ, Senior Consultant, Anantapuri Hospital, Thiruvananthapuram. And our third topic is a case discussion on tonsillectomy by it will be presented by Avani Sanjeevan from Government Medical College, Kottayam, and the examiners will be Dr. Shanti KS, Professor, Additional Professor and Head of the Department of Government Medical College, Kottayam, and Ashish Karthik, Associated Professor of Government Medical College, Thrissur. So this will be an interesting program. I hope so. I request all the PG students to join us at 6 p.m. on next Saturday. We can receive the comments from our seniors if they are present. And if Vijay sir, if you want, you can address the chat box questions. Few questions were there in the chat box.
I didn't see. Okay, fine. Difference between ODC and myoglobin curve can also be asked. Okay, that is for the PGs. The oxygen dissociation curve and myoglobin. So the myoglobin, the issue is it'll catch hold of only one oxygen, and it's a hyperbolic curve. Whereas the ODC is a sigmoid shaped curve, and here hemoglobin will hold on to 4 molecules of oxygen, right? Is the question to me or to the PGs? PGs should not answer.
Anyhow, no problem. We got the
next
answer.
one is we can use isoflurane, but because halothane preservative can stuck the dial. Yes, absolutely correct. Halothane has a preservative called thymol, and halothane will get evaporated. I mean, it will vaporize faster, and thymol will be left behind. And this thymol will cause the dials to get stuck. Absolutely correct. The next thing that is asked is nephrotoxicity of compound A proven in humans? No. Nephrotoxicity of compound A is not proven in humans. It is proven in rats and non-primate humans. And there are studies. It is there are a few studies in which the experimental indicators of renal injury increased in humans. However, the usual your lab test has not so far detected nephrotoxicity as far as I know. That's the only, and steps taken to control when you suspect malignant hyperthermia. I think Safa will answer that. She's gone.
No, sir.
Yeah, what are the steps that you will take to control when you suspect MH? That is, what are the steps that you will do?
We have to inform the surgeon and stop the surgery and flush the breathing circuits. Then change the carbon dioxide absorbent. Then terminate the inhalational agent. 100% oxygen is given. Then cooling measures are given with cold IV fluids, ice packs like that. We try to control the temperature. Then Dandrol.
Yeah, correct. Very good. So these are the things that we can do. So, and if there are activated charcoal filters, VapoClean filters, we can put that in the inspiratory and expiratory limb, and then you run the machine for 15 minutes, and it will get. They say that even in less than 5 minutes, it gets it will reduce exposure to less than 5 parts per million. So it's a thing. If you can get it, you can put it and do it. Otherwise, you'll have to run the anesthesia machine at 15 liters per minute, 100% oxygen for a long time. And suppose the incidence of this malignant hyperthermia is very high, you should have a machine in your department where you don't use volatile anesthetic agents on that machine. And that probably it is not that high in our country, so it is not done. But in New Zealand, in one province in New Zealand, I forgot the province name, there 1 in 2,000 people have developed malignant hyperthermia. So where they keep in their anesthetic department a machine where volatile anesthetic agents are not used. There will be a separate machine. So if the patient is suspected, they will use that machine.
Okay.
Thank you, sir.
There is one more question in the. Is there any direction on time gap between anesthesia on single patient? I did not understand. Is there any direction on time gap between anesthesia on a single patient?
Maybe the interval between two anesthesia. Maybe they are asking.
Yes, that is Dr. Murali is asking.
Yeah, correct. That's my doubt.
You can ask directly, Dr. Murali.
Yeah, how frequently we can give general anesthesia for a patient? I mean, for multiple procedures, and is there any direction on the spinal anesthesia? The interval between two spinal anesthesia, is there any such directions?
Nasser sir will answer that question.
Yeah, I am not aware of it. I'm sorry for that. Because we give very.
No, because in the discussion part, Mubarak sir was mentioning that there is the previous GA was 1 year back. So I just thought, is there any such guidelines?
Only are you mentioning regarding the existence of malignant hyperthermia or just as a general?
General
anesthesia. You have to individualize the scenario. There is nothing called nobody will anesthetize a patient simply for any reason. No, so it all depends upon the individual case and analysis. I thought it was regarding the repeat anesthesia after incidence of malignant hyperthermia.
No. My question is regarding this. Yeah. And another doubt is regarding the spinal part, spinal anesthesia.
How frequent you can give spinal? Okay. Suppose you fail one spinal, can you give another spinal? We usually give.
Definitely.
Yes, definitely.
And there are protocols for that.
Okay.
And for TURP and all now, suppose the patient has got rebleeding, we take again for into the OT and give spinal anesthesia only, same day.
On the same day.
Yeah.
Yes. And for this microvascular procedures, we used to give repeatedly twice or thrice like that within a week or so.
Yeah.
Only thing we must be careful about is the PDPH. If it
It's not, suppose a patient has a post-tonsillectomy bleeding, we take an immediately anesthetic, no?
Yeah, that's true.
It's all depend upon the individual case. Can't make a generalized. Yeah.
Yeah.
Okay. Thank you, sir. And I think with this we will conclude our academic session. And now I thank our anesthesia TV team, Mr. Rahul and Mr. Sam, for live streaming our program. So we actually around 230 participants joined today for our program. Around 210 were in the Zoom and rest were in the YouTube. And I thank Mubarak sir and Vijay sir for this excellent program, excellent OSCE program. And I congratulate our students, Dr. Fasna and Dr. Safa Kunin, for performing very well. I hope they have performed very well in this program. Actually, we should get the opinion from the moderators itself. Mubarak sir can contribute.
It was, we had taken 29 topics actually. Myself, I had put 15 questions, and from which it was 14 questions. It was those postgraduates, the first and Safa should be appreciated and congratulated for giving prompt answers to such a vast topics, and this is a new type of PG teaching, and I also thank the organizers for giving us the opportunity and chance. And this was a real experience for us for preparing and conducting such a program. And both of them has done wonderfully well. And I thank them and congratulate them well.
Mubarak sir and Vijesh, it was Dr. Vijesh and Mubarak sir, it was excellent matrix of questions from instruments, equipments, from covering all different types of anesthesia.
We try to include a question from different areas, right from the history to the recent COVID-19, from as much as possible, monitoring, drugs, pharmacology, anatomy, physiology, critical care, anesthesia, ICU, so many aspects we try to cover as much as possible within this 2 hour. It has extended to almost 3 hours now. So,
sir, it was an excellent program. Thank you.
Yeah,
Thank
yeah,
you.
yeah.
And since they have answered very well, they have participated very well, we should award a certificate to them. So I request our president, Dr. Nasser, to award a certificate to Dr. Safa Kunjin. Nasser, sir, please.
This was an excellent program, Safa. We, the state branch, really appreciate your answering that, and the moderators have covered the entire topic. It was a review exam, I can tell that. Kindly accept the certificate from the state branch. Dr. Safa Kunjin, please.
Yes, sir. Thank you so much, sir. Thank you.
You're done well. Okay, all the best.
Thank you for all your
Safa
support.
is from KMCT Medical College, Calicut. She is a PG resident, and her HOD is Dr. Vijesh Venugopal. So congratulations to proud teacher and to student.
Thank you, sir. Thank you so much.
And next is our Dr. Fasnayan, senior resident from Government Medical College, Calicut. Nasser, sir, please.
Dr. Fasna, you also contributed well, and it was really useful. Many of our postgrads, even from our institute, they tell that it was a total coverage of the entire exam. You are done well.
Thank you, sir.
Please accept our certificate from the Kerala State Chapter. Dr. Fasna, done well. All the best.
Thank you, sir. Thank you, Mubarak sir.
Thank you, Fasna. Thank you, Safa. You are done very well.
Thank you, sir. Thank you, Mubarak sir, and thank you, Vijay sir, for giving us such a great opportunity.
And another thing, Safa was my student for diploma in Calicut Medical College too. So I'm proud of her too. Okay. And Fasna, actually, Fasna is she joined as a postgraduate of mine at Trichy Medical College, and later I got transferred to Calicut, and she has been trained by Dr. Shamshad and team at